Good morning and welcome to the final day of the 7th International Pediatric Hematology Conference. Over the past 2 days, we have witnessed exceptional science, thoughtful dialogue, and meaningful collaboration. Today offers a fitting conclusion to what has been a truly outstanding meeting. Our program today continues to showcase pioneering work across hematology, critical care, and related disciplines. I encourage you to remain engaged and reflective as we bring this conference to a close. On behalf of the organizing committee, I thank our faculty for their generosity and our delegates for their active participation. Your presence has made this conference a success. Let us make this final day as impactful as the ones before it. Welcome again and thank you. So our first speaker is Dr. Susan Halima, Medical Director, Medical Director and Partner at Grünenstadt, Rhine-Ruhr, Germany, attending physician hemophilia and thrombosis treatment center, University of Duisburg-Essen. A specialist in complex coagulation disorders, Dr. Halima provides gold standard clinical care at one of the Germany's premier centers for hemostasis and thrombosis research. Welcome, Dr. Halima.
Good morning, everyone. I give you an overview about the Glanzmann thrombosthenia and the inherited platelet function disorders. I give you the first overview in molecular biology, then diagnosis and therapy, and a real patient case at the end. A quick overview of the 6 parts. Part 1 to 3, the disease, molecular basis and diagnosis. Part 4 and 5, therapy and special situations. Part 6, differentiation, key messages and the case. Glanzmann is a rare autosomal recessive platelet function disorder. The prevalence is roughly 1 in a million, higher where consanguine is common. The key point is platelet count and morphology are normal. The defect is purely functional. The bleeding pattern is mucocutaneous and lifelong. The 3 types by visceral receptor. Type 1 under 5%, type 2 5 to 20%, virulent type nearly normal but not functional. Remember, visceral receptor predicts bleeding poorly. The virulent type is trichyceous because flow cytometer can look normal, so test the function. Alpha 2b beta 3 is the fibrinogen receptor and the most abundant platelet integrin. Both subunits must assemble together, otherwise nothing reaches the surface. The receptor switch between an inactivate and active shape. Beta 3 also appears in an alpha view beta 3, which matters with ITGB3 defect. Signalling from the inside out, agonist G protein effectors tyline and kynurenine, then active receptor. In Glanzmann, the defect site right at the end and the receptor itself. That is why shape change and secretion still work, but aggregation fails. Variant class explains receptor biology. Null variant give classic severe type 1. Missing can hit folding, binding or activation. Managed by bleeding history, not by genotype. We have 5 steps. Bleeding score, exclude plasmatic causes, aggregometer, flow cytometer, and the genetics. The lab signature on the right, normal count absent aggregation, but preserve resuscitate response. That last point is the key distinction from Bernard Solier. 4 building blocks: receptor quantity, PAC1 as an activation marker, fibrinogen binding, and Y flow is practical. The advantage: small samples works in thrombocytopenia and neonates. But we have to look for complex antibodies can read facially low environment. Work in tiers. Panel first, then exome, then genome. Confirm and phase, because in a recessive disease the variant must sit on the different alleles. Value. Resolve the variant type, separate through GT from phenotypes, and enable counseling. 3 pillars plus definitive options: local measures with antifibrinolytic platelets and recombinant 7A. Core principles: minimize platelet explore, lifelong to avoid immunization. Recombinant 7A is the backbone, especially with antibodies. The GT register is the main real-world evidence base for recombinant 7A. 96 patients, 206 procedures, 37 from them were major. High hemostatic success regardless of antibody status. Thromboembolism was very rare. This table is the dosing references. Recombinant 7A around 90 micrograms per kilo every 2 hours, always with an antifibrinolytic medication. Tranexamic acid as the baseline adjunct. Platelet only sparingly. Important, these are representative values. Local protocols must be applied. 3 tiers: minor, moderate, and severe. In minor, local measures plus tranexamic acid. Moderate, add recombinant 7A. And in severe, recombinant 7A first, and reserve HLA match platelet if antibodies are present. Always check antibody status. Repeated platelet transfusion can trigger antibodies against the receptor or against HLA. Consequences: refractoriness, and in women NIAT risk for the baby. Strategy: prevent, detect, treat with recombinant 7A. Rescue with matched platelet and transplant as a definitive step. 3 phases: plan, cover, and monitor. And before, involve a center, antibody screen, secure platelet, and during, recombinant 7A before the incision and every 2 hours plus tranexamic acid. After, watched for delayed bleeding and for thrombosis. Pregnancy is a very high risk, especially after delivery. Multidisciplinary team and regular antibody screening. Aim for an untraumatic delivery in a center with matched platelet. For the neonate, keep NIET and the risk for intracranial hemorrhage in mind. Lentiviral approach. Harvest the patient's own stem cells, insert the gene and the platelet, then express the receptor. Status: animal model successful. GMP manufacturing achieved but still investigational. Transplant remain the only cure. Glanzmann in the context of function disorders. The key differences in the resuscitation response preserved in GT, absent in Bernard Solier, others, storage pool, gray platelet signaling, and Scott syndrome. 5 key messages: function over numbers. Recombinant 7A is a workhorse. Use platelets sparingly and plan high-risk events ahead. Cure by transplant with gene therapy on the horizon. Now my case: Mohammed Ilyas, 18 years old, morbus Glanzmann. A 12-year course managed by recombinant 7A. The target joint is the right ankle, upper ankle. The diagnosis was very early. A brother 1 year younger is also affected. A very active child with frequent injuries. Treatment first on demand, then regularly prophylaxis. The on-demand area from 2012 to 2017 typically fall and impact bleeds, each treated acutely with recombinant 7A. In 2017, the first bleed into the right ankle, the start of the real problem. From 2018, repeated bleeds into the right ankle. MRI and ultrasound shows synovitis, early arthropathy. This joint dominates the entire later course. First two radiosonophatesis procedures, unfortunately without any success. Prophylaxis established in 2020, the open surgery arthrotomy with chondroplasty. On the right, I show you the perioperative recombinant 7A schedule, additional with tranexamic acid. October 2020, screw removal with an own schedule. Recovery is slow after a month, pain-free, walking up to 45 minutes. The patient is satisfied with his gait. Stabilization from 2021 to 2024, range of motion stays limited but largely pain-free. Prophylaxis steps up when needed. By 2024, a stable picture with no complaint. This is the photo documentation over the years. 2019, the ankle and the face. 2020, the surgical size. And 2022, stabilized with a small pedicle bleeds. The target joint is the right ankle. Escalation from radiosonophatesis through arthrotomy to screw removal. And the outcome was pain-free with good daily function, currently 5 milligram of recombinant 7A twice weekly. And these are my references through my presentation. And for further questions, please email me. I will answer very quick. Thank you very much.
Thank you so much, Dr. Susan, for the excellent. Thank you so much, Dr. Halima, for the excellent presentation. We move now to the next speaker. Our next speaker is Professor Immacolata Andolfo. Professor Immacolata Andolfo, Professor of Medical Genetics, University of Naples, Italy, and Head Analytic Phase Kinge Institute, Naples, an internationally renowned genetist focusing on red blood cell disorders. Professor Andolfo's laboratory is at the forefront of research into the piezo-1 mechanoreceptor and hepcidin regulation, significantly advancing the molecular understanding of hematological genetics. This is a recorded presentation.
Hello everyone. First of all, I'd like to thank the scientific committee for this kind invitation. It's a very pleasure for me to be here for this international conference. I will talk about genetic basis and diagnostic approaches in red blood cell membrane defects. These type of conditions are very heterogeneous, and we can subdivide in this type of inherited anemia in red blood cell structural defects and red blood cell ion transport defects. And I will show you the genetic basis, the diagnostic approach, the differential diagnosis of this condition. As you know, the blood cell membrane and cytoskeleton work together to ensure shape, mechanical resilience, and flexibility of the red blood cell. So mutation in any genes encoding for protein localized in the plasma membrane or in the cytoskeleton accounts for a red blood cell membrane defects. This type of condition can be classified in red blood cell structural defect and red blood cell transport defect. And first of all, the diagnosis of this condition is made by a conventional workflow comprising 3 lines of investigation. The first one is the evaluation of the complete blood count, the evaluation of the peripheral blood smear with the specific alteration of the morphology of erythrocytes, and the evaluation of family history and transmission pattern because they are inherited condition. As a second line of investigation, we have biochemical tests such as osmotic fragility test, pink test, SDS page, and also HEMA test that is very useful for this type of condition. This is a flow cytometric assay in which we highlighted the presence of BAN3 and the plasma membrane of red blood cell. And particularly in hereditary spherocytosis, we have a decreased level of HEMA binding test because there is a decreased expression of BAN3 at the plasma membrane of red blood cell. Another important assay is the ectacytometry. Ectacytometry is a viscometer that measures the red blood cell deformability and hydration status. And we have a specific curve for each type of condition compared to healthy controls. As a last line of investigation, we have the genetic testing that can be made by using direct sequencing of causative gene or next generation sequencing, both custom panel and full exome sequencing. In my laboratory, I use a red panel that is composed by 125 genes that are causative of different red blood cell defects and also iron metabolism defect. So all the possible differential diagnosis of membrane defects. Moving to the red blood cell structural defects, in this type of subgroup, we have the hereditary spherocytosis, hereditary elliptocytosis, and hereditary pyropoikilocytosis. Hereditary spherocytosis is the most common non-immune hemolytic anemia. As a first line of investigation, we have a normocytic anemia with increased MCHC, positive hemolytic markers such as increased reticulocyte count, increased LDH and indirect bilirubin, and also decreased level of haptoglobin. We have splenomegaly and gallstones, and it is important to highlight that splenectomy is beneficial in severe cases of hereditary spherocytosis. At peripheral blood smear, we can observe a variable number of spherocytes and also other alteration of red blood cell morphology such as mushroom red cell, acanthocytosis, and so on. And at the second line of investigation, we have a decreased level of HEMA binding test and a specific curve of the ectacytometry with a decreased deformability and a right shift compared to the healthy controls that indicates a decreased deformability and an overhydration of red blood cell. As a third line of investigation, the genetic testing is performed by the analysis of the causative genes that are ankyrin, alpha-spectrin, beta-spectrin, BAN3, and protein 4.2. we have different transmission, both autosomal dominant transmission and autosomal recessive condition, and all the mutation in these genes account for defects that interrupt the vertical interaction of the cytoskeleton with the protein of the plasma membrane. Recent genotype-phenotype correlations highlighted that mutation in ankyrin 1 and beta-spectrin accounts for the more severe phenotype in hereditary spherocytosis, and moreover, in this cohort of patients from Netherlands, we have 33% of patients carrying SPTA1 mutation in an autosomal recessive form. That is very unusual compared to the past. On the other hand, hereditary elliptocytosis is characterized by the presence of elliptocytes on peripheral blood smear. The majority of patients present no anemia or hemolysis, and it is caused by defect in horizontal interaction of the cytoskeleton. The causative genes are alpha-spectrin, beta-spectrin, and protein 4.1 with an autosomal dominant transmission. The ectacytometry curve highlights a specific curve that is this one, like a trapezoid. Hereditary pyropoikilocytosis is the most severe condition in the group of structural defect of the membrane, and it is characterized by the presence of poikilocytosis at the plasma, at peripheral blood smear, and also the presence of fragmented erythrocytes, resulting in low MCV, about 50-16 femtoliter. It is a recessive condition caused by biallelic mutation in SPT1, and we can have also the co-inheritance of some hypomorphic polymorphism in alpha-spectrin, like alpha-allele allele, that is a specific splicing mutation that account for a reduction of about 30% of the expression of alpha-spectrin. We can have also diagenic inheritance caused by mutation in both SPT1 and SPT genes. So, moving to the other group, that is the red blood cell transport defects. In this type of subgroup, we have both syndromic and non-syndromic condition. Within a non-syndromic condition, we have dehydrated hereditary somatocytosis, overhydrated hereditary somatocytosis, cryohydrocytosis, familial pseudohyperkalemia, Southeast Asian ovalocytosis. Within the syndromic condition, we have GLUT1 deficiency, phytosterolemia, and syndromic form of DHS. The fourth syndromic condition is the deficiency of GLUT1. It is a rare form of somatocytosis associated with a coal-induced cation leak, so an alteration of the permeability of red blood cell to membrane, with hemolytic anemia, hepatosplenomegaly, cataract, seizure, learning disability, and ataxia. The transmission is autosomal dominant, and it is associated with the mutation in SLC2A1 that codifies for GLUT1 transporter, causing both loss of glucose transport and a cation leak. Phytosterolemia is a lipid metabolic disorder in which there is an increased serum concentration of sterols with the presence of somatocytes at peripheral blood smear, hemolytic anemia, and also macrothrombocytopenia with an autosomal recessive and genic inheritance, because we have two causative genes that are ABCJ1, J5 and ABCJ8 that codify for two ATP cassette transporter that mediate efflux of sterol from the small intestine. So this type of protein are not expressed in the plasma membrane or red blood cell, but are expressed in the small intestine. And so the incorporation of sterols into red blood cell results in abnormal morphology and function of plasma membrane and also splenomegaly. There is no presence of cation leak, so no alteration also of ECTA cytometry analysis. Another form of non-syndromic ion transport defect is the cryoerythrocytosis, that is a mild somatocytic hemolytic anemia with increased level of bilirubin and a potassium efflux at low temperature. It is associated with mutation in BEN3 with an autosomal dominant inheritance. In this case, the mutation converts BEN3 from an anion exchanger into a cation channel, which is a pathogenic mechanism completely different from the loss of function mechanism that causes hereditary spherocytosis. Another condition is the southeast ovalocytosis, in which we have a red blood cell alteration common in Malaysia, Indonesia, Philippines, and Papua New Guinea, and it is inherited as an autosomal dominant condition, and it is caused by this specific deletion in SLC4A1 gene that encode for BEN3. And in this type of condition, we have specific ovalocytes at peripheral blood smear, and also the presence of these peculiar red blood cells that are theta cells. This one. Another non-syndromic ion transport defect is the overhydrated hereditary stomatocytosis, that is an autosomal dominant hemolytic anemia characterized by an increase in the monovalent cation leak, also associated with the absence of somatin. The causative gene is RHAG, that is an ammonium transporter, and on peripheral blood smear we have more than 20% of stomatocytes, and at ectacytometry we have a right shift of the osmolarity curve of the patient compared to the healthy controls. Another non-syndromic ion transport defect is the pseudohyperkalemia, that is a dominant inherited genetic trait characterized by temperature-dependent in vitro loss of cation from red blood cell. So we have an increased plasma potassium level when the blood is stored at or below body temperature. The patient show only a mild increase of MCV and in some cases hyperkalemia. The causative gene is ABCB6, and we have both heterozygous and homozygous mutation in this gene that account for this type of condition. And it is very important to identify mutation in ABCB6 gene, because we have demonstrated that variants in this gene are present in healthy subjects and also in blood donor population. And the storage of blood from this patient causes a significant increase in blood potassium levels, causing problems mostly in pediatric neonatal care, indeed several cases of poor blood transfusion in infant, leading to cardiac arrest and death have been described. So genetic tests for familial pseudohyperkalemia could be used to screen potential donors of blood. Another condition is the dehydrated hereditary stomatocytosis that is the most common within the ion transport defect. In this case, we have both syndromic and non-syndromic condition. It is an autosomal dominant hemolytic anemia associated with a cation leak, so an alteration of the permeability of the plasma membrane of red blood cell to cation. We have two causative genes for this condition that are piezo1 and KCNN4. Piezo1 account for about 90% of cases of DHS. It is a rare condition, but we have demonstrated that it is rather underdiagnosis, and a recent study estimates an incidence of 1 case in 80,000 adults, and it is also linked to malaria resistance. The diagnostic workflow DHS is the same that we performed for the red blood cell, all the other red blood cell membrane defects, but in this case I have to highlight that at peripheral blood smear, we have a variable number of stomatocytes that are between 5 and 20%, but we have several cases in which we have the absence of stomatocytes at peripheral blood smear. We have an autosomal dominant transmission. As a second line of investigation, we have no alteration of the IMA binding test, and at ectacytometry, we have a left shift of the osmolarity curve in the patient compared to the healthy control. And it is very important to highlight that as a third line of investigation, it is very important to perform the genetic testing, because for piezo1 we have several problems of detection of variant and classification of variant in this gene. So DHS is defined as a pleiotropic syndrome characterized by several phenotypes that you can see in this image. So we have the alteration of miniature red blood cell with alteration of deformability, dehydration, and resistance to malaria. We have also an alteration during erythroid differentiation with an impairment of terminal erythroid differentiation. We have several cases of thrombosis after splenectomy, and we have also the hepatic iron overload that is very severe. So, pathogenic gain of function variants in piezo1 act by delaying the inactivation of the channel. So we have an hyperactivation of the channel. The channel is this. Is a trimeric propeller-like structure. It is a mechanoreceptor, so we have several mechanical stimuli that account for the opening of the channel. And when we have the gain of function mutation, we have an increased intracellular calcium concentration, we have an increased efflux of potassium, and we have also an osmotic efflux of water that accounts for dehydration. So the main characteristics are, in most of the cases, macrocytic anemia, but we have also many cases of normocytic anemia, positive hemolytic markers, splenomegaly and gallstones. And it is important to underline that splenectomy is completely contraindicated due to the increased risk of severe thromboembolic complication. At the peripheral blood smear, we have a variable number of stomatocytes. In the syndromic condition, we have the presence of pre- and perinatal edema. We have also pseudohyperkalemia, very similar to the isolated pseudohyperkalemia form. And we have the severe iron overload with an increased level of ferritin, transferrin saturation, and liver iron concentration. Regarding the genetic testing for piezo1, it is very difficult to classify variant in piezo1 because piezo1 is characterized by allelic heterogeneity, relative tolerance to missense variation, and the presence of overlapping clinical phenotype. So in this recent study, we applied an integrative framework combining ACMG guidelines, quantitative in silico prediction, structural domain annotation, and detailed patient phenotype to classify more than 2050 and 500 piezo 1 variant, and we reclassify about 1000 variant of uncertain significance, and we also performed the second genotype-phenotype correlation in this type of patient, highlighting non-random clustering of pathogenic variant in functionally constrained domain. So specific variants are enriched in particular phenotype contexts, and so I think that it's very useful for both clinicians and laboratories to perform the genetic testing for piezo 1 in this type of hemolytic anemia. The second causative gene of the condition is KCNN4 that encodes for the Gardos channel, an erythroid calcium-sensitive potassium channel. The family described until now are very few, and the mutated channel show an higher activity, so also in this case we have a gain of function phenotype. Regarding piezo 1, we have also some patients carrying specific piezo 1 mutation that show the reduced reticulocyte count compared to the degree of anemia. Some experimental condition, CD34 positive cell from piezo 1 patient induced to erythroid differentiation show delay in erythroid differentiation, so we have some peculiar characteristic of stressed erythropoiesis, and for this reason there are also some cases of dehydrated hereditary stomatocytosis that are misdiagnosed as myelodysplastic syndrome, and these are 3 examples of case report in which we have mutation in piezo 1 that account or for only DHS or cases of coinheritance of piezo 1 germline mutation and also some somatic mutation of myelodysplastic syndrome. For this reason, in a study in collaboration with Professor Santini 3 years ago, we analyzed MDS patient defined young, so with an atypical early onset of the disease and anemia as the main cytopenia, and we demonstrating that in 24% of patients we have a pathogenic variant in piezo 1, and we have also patients with iron overload, gallstone and splenomegaly, and we think that the concomitant presence of an inherited red blood cell defect and MDS could accelerate the appearance of anemia, determining an early clinical onset of MDS, but future studies are needed to clarify the role of piezo 1 as a potential predisposing factor for the development of clonal diseases such as MDS. And regarding the hepatic iron overload, in patient carrying gain-of-function piezo 1 variant, we have an hepatic iron overload that is independent of the degree of anemia and the transfusion rate of patient with very low level of hepcidin and only a slight increase of erythroferron, so the only erythroid regulator of hepcidin. For this reason, we demonstrate in cellular hepatic model that piezo 1 gain-of-function mutant show decreased expression of hepcidin, so very similar to the patient, with an increase in intracellular calcium concentration similar to red blood cell, and alteration of several pathways such as ERK1/2 and also the BMP-SMAD pathway that is the main signaling pathway that account for the regulation of hepcidin transcription. And also in the mice models, both constitutive and macrophage specific gain-of-function piezo 1 mice, we have iron overload. So there is a specific and direct role of piezo 1 at hepatic level. And for this reason, The DHS, so dehydrated hereditary stomatocytosis, also called hereditary xerocytosis, we have a differential diagnosis, first of all, with the hereditary spherocytosis, because we have some overlapping features, but we have also the ectacytometry that is very different into two condition. We have a misdiagnosis with congenital dyserythropoietic anemias, mainly type 1 and type 2, because we have also dyserythropoietic features. And we have also the misdiagnosis in some cases with myelodysplastic syndromes, because we have, for the same reason for which there is the overlapping with the congenital dyserythropoietic anemias, because piezo-1 account also for cystic erythropoiesis. And we have also a misdiagnosis with hereditary hemochromatosis, because we have several cases of absence of anemia and presence of hepatic iron overload, so very similar to hereditary hemochromatosis. So it is very important to perform genetic testing in this type of condition, because we have also several cases of co-inheritance with other genetic trait. For example, we have studied co-inheritance with beta thalassemia trait. So we have a patient with anemia that is atypical in beta thalassemia trait, and with the presence of low MCB. And we have also other cases of multilocus inheritance of DHS with hereditary spherocytosis or congenital dyserythropoietic anemia. And in this case, we have alterations that are not peculiar of the single condition if we evaluate the first and the second line of investigation. So genetic analysis is crucial for the diagnosis of this type of condition. So the take-home messages are that the diagnosis of red blood cell membrane defect is very challenging and comprises 3 lines of investigation that are strictly dependent for each other. The genetic analysis is crucial to reach a correct diagnosis and to assess the possible presence of multilocus inheritance. Remember that red blood cell membrane defect could be related to iron metabolism defect for DHS and mutation in piezo-1, and new therapies are under development. So I thank you for the attention, and also I'd like to thank my research group at the University of Naples in Italy, and also at the Changing Institute. We have all the diagnostic unit on medical genetics that perform also the analysis of red blood cell and iron metabolism defect. I'd like to thank my mentor, Professor Achille Iolascon, and also my colleague, in particular, Professor Roberta Russo. Thank you. And if you have any question, you can write me to this email address. Thank you. Hello, everyone.
Thank you so much, Professor Aldolfo, for the excellent presentation. We move now to the next speaker. Our next speaker is Professor Jacob Newberg. He's an associate professor, Department of Radiology, St. Jude Children's Research Hospital, a visionary at the frontier of artificial intelligence in medicine. Professor Luber's groundbreaking research published in Nature and Engine AI is pioneering new methodologies in AI-driven diagnostic and predictive analytic for pediatric hematology and oncology. Welcome, Professor Luber.
Thank you for the presentation to speak today, Dr. Almadi. Can everyone see my screen all right?
Yes.
Fantastic. Again, thank you for the invitation to speak. Today, I'll be presenting Harmonizing the World's Sickle Cell Data, and I'll be talking about a federated global registry and the AI engine that we built to make this scale. So I'm going to talk about this in two vignettes. The first is how we build multimodal cancer foundation models in oncology, and then how we apply that to benign hematology in the context of the global sickle cell registry. And so I just want to take a moment to talk a little bit about the legacy of impact at St. Jude Children's Research Hospital. We are the largest and most well-funded uh, pediatric healthcare nonprofit organization in the United States. And we were founded in 1962 by Danny Thomas, who was an American immigrant and children of Lebanese immigrants to the United States, who founded ALSAC, the American Lebanese Syrian Associated Charities, that runs our hospital to the modern day. And in our impact, we bring clinicians, researchers, biostatisticians, and IT professionals together. So the talk today will span about how we bring foundation models to clinical practice. So in 2024, my group published the first evaluation of foundation models. So in clinical medicine, we would define a foundation model as a machine learning model that we train on a large amount of clinical data, and then we can apply it to other different downstream clinical tasks. And we began to evaluate multimodal and imaging-based foundation models and published this as a New England Journal of Medicine AI case report. This was led by HEMONC fellow Helen Shang and PhD students in my lab, Mohammed Nasser and Parisa Malidara. And from this work, we got a Google Research grant. And this work has been led by PhD student Lucy Pham in my group, where we're building AI models to input a clinician inquiry. So the query the clinician would ask, is the reported mutation in a patient's lung biopsy consistent with the imaging features and current treatment guidelines? And then we integrate EHR records, medical imaging, omics data, and clinical guidelines. And then we validate those against each other and then use this to ground the AI. And this is going to be a key idea that we talk about in our sickle cell context also, about how we use AI to scale up building registries between countries. And so in oncology for the past 4 years, my group has used AI to parse the largest guideline knowledge base of clinical decision making, as well as the largest multimodal oncology data set with for specific tumors, prostate, breast, colon, and lung, where we've parsed 84 million records. And we're beginning to use these tools to benchmark where foundation models fail in clinical medicine. These two assets power 4 open downstream clinical programs. And so what this enables is grounded foundation models. So rather than an AI model that hallucinates, these models are version traceable, multimodal, and have multimodal reasoning with openly released model weights. We can also study guideline adoption at scale. We can begin to do population scale analysis of how guideline changes reach clinical practice, uptake, lag, and disparities. And we can begin to look at exploration and reader study tools to look at interventions, and then begin to build open source decision support tools. So I'm going to give one quick vignette of how this applies in clinical practice, and then we'll move to fully talking about how this translates to the sickle cell disease ontology and global sickle cell registries. So on the left is a visual representation, and the data that I'm going to present today for both our cancer and sickle cell vignettes is all unpublished work at St. Jude that is in progress. is that we began to parse tens of thousands of treatment guideline recommendations in oncology and look at where and map from these tens of thousands of pages a grounded resource to train foundation models to look at when clinical trials happen for different drugs and longitudinally. And so we looked at when different treatments were recommended, acknowledged, upgraded, downgraded, edited, removed, and then in the US had FDA approval or FDA approval withdrawn, as well as how solid the evidence in the literature was for new treatment recommendations. Then on the right, let me make this smaller. We began to trace through our 40,000 patient cohort that our lab has put together with 84 million records when adoption of these treatment practices began to happen. And we began to see that, sorry, we began to see things like clinical trial leakage, where before endpoints were released, physicians were seeing uh, um, abstracts at conferences and reading the literature for preliminary results and beginning to prescribe drugs. And this schematic of differing treatments from 2013 to 2025 um, for NSCLC metastatic lung cancer shows the problem of making accurate clinical AI interventions. And that if you look at any point in time, there's around three valid clinical choices to make. So the AI has to contextualize this to make a valid choice. So we've begun to do pre-specified retrospective concordance studies to look at how AI performs. So in our cohort, collaborating with Arash Naeem at UCLA, the chief clinical medical officer, we looked at every ALK plus patient that came through the door last year. And then we put their clinical summary into the first HIPAA compliant version of OpenAI ChatGPT 5.4, as well as tested this on our own foundation model and found that first opinion patients, the frontier AI models got perfectly right. And that, sorry, and that second opinion cases, the AI failed either looking at the clinical genomics, staging, clinical course, or treatment recommendation, and competently failed all of these. So we stratified cases by splitting these prospectively by consult type. And that this is an administrative field set before grading, not difficulty judged after the fact. And we said that a first opinion is just initial consultations, treatment naive, and that a second opinion was a patient already on therapy referred for review. And so we had a group of oncologists review the AI recommendations and score them as either correct or incorrect based on perfect concordance. And then we saw a Fisher exact p-value of 0.002 for the complex versus second opinion cases. And we then broke this down into a primary composite endpoint with secondary endpoints that the AI failed on complex cases. And that this is a property that we see of foundation models in clinical medicine, that distribution in the training data is really important. So the AI models have been trained on board exams for simple cases, and it passes all of those. When we see any complex case, the best AI models released in the past few months at the frontier fail to make the correct clinical reasoning. So how we ground AI systems to have accurate clinical performance is a crucial problem. And so I've now sort of laid the framework for how grounding AI systems is a massive problem. And I'm now going to spend the rest of in the majority of my talk talking about a collaboration between my group and Jane Hankins. So Jane is also a faculty member at St. Jude. She's the director of our global hematology program and recently passed the reins of leading the sickle cell script consortium to Deepa Mamwani and is still actively involved. And then all of the AI for sickle cell research that I'll be presenting today is in collaboration with Andrew Smith, Paul Yee, and Pritam Mukherjee. And so, what are the stakes in that sickle cell, as you all know, is a catastrophic blood disorder on a global scale? Uh, it's one of the most common severe inherited disorders in the world, yet most patients live where data and therefore evidence are scarce. And so we're building a unified AI sickle cell registry built on the St. Jude Global Alliance, where we have 83 countries, 460 partner institutions, and 76 supporting foundations. But we're flying nearly blind. So less than 2% of the world's people with sickle cell disease are captured in any data registry anywhere. So this is a fundamental problem because what we cannot count, we cannot improve. The Global Hematology Program at St. Jude has both a mission and a vision. The mission is to advance and innovate the field of non-malignant catastrophic blood disorders worldwide through network building, tool design, and implementation research, where ultimately we want to enhance survival and outcomes. And our vision is to shape a world where every young person with non-malignant catastrophic blood disorders receives specialized, compassionate care, leading to a long and fulfilling life. We've begun to take the lessons we've learned from building large-scale foundation AI models in adult oncology to building sickle cell registries. And the big problem we have is that the data we have doesn't speak the same language. So existing sickle cell disease registries were each built in isolation. So we can look at SCDC, Hutton, Real Answers, WebHemo, CONSA, GRNDAD, NHRUK, Inherent, Pen Plus, SCDIC, Sparco, and then the script registry from the consortium at St. Jude. So they overlap little, they define variables differently, and they rarely interoperate. So they fragment our view of a single disease. So across the 12 largest sickle cell registries, there's 6,238 clinical variables. And so the alliance of partners that is working on the registries with sickle cell disease already spans 6 continents that Jane's group is spearheading. So she provided me this slide where I've shown members of the consortium in dark blue countries that have been approved by our executive committee but have agreements yet to be signed, and then in yellow countries that are pending review by the executive committee. When we want to build a new sickle cell registry to capture more than 2% of patients' data globally, the problem is that the global burden of catastrophic non-malignant blood disease is significant. And the gap is that the unavailability and fragmentation of data limit our understanding of the scope of the problem and progress on potential solutions. So what we're proposing is using AI to build a global registry for hematologic diseases, leveraging a federated data model and the existing registry information at St. Jude. And so we wanted to step back and ask a question, what we can do if we actually succeed in this task and have a global registry. So we can begin to do better quality improvement studies. We can look at and cross-institutional collaborations. We can consider research for the selections of clinical trials, synthetic arms, and cohort studies. Like I presented the guideline-related research in oncology, there's many efforts such as the ARIA Consortium for resource-adapted guidelines uh, um, to look at benchmarking quality indicators and make treatment more standardized across different resource environments. This can inform advocacy efforts and policy development, and it can help with population level surveillance and data harmonization. And that most importantly, we think that beyond helping individual patients at a macro level, this can turn into a data platform for scaling cures. And that these are common data elements needed for evaluating gene therapy trials in the future for sickle cell. And so, as we build a registry before we get into the AI topics, we want to think about a functional template. And for us, the functional template is a global hospital-based cancer registry network. And that this existing registry has 100 institutions across 23 countries and 30,000 patients enrolled, built on the Trial Master platform with 90% of variables standardized for all sites. It has alignment with population-based registries and multi-language support. And so in terms of operation implementation, data standards are designed for LMIC specifically. There's training for registry site members, as well as secure cloud-based a tool for data capture. And building this type of standardization across institutions, countries, and variables involves a massive amount of curation effort. So the task that we've been working on for the past year or so is starting to use AI foundation models trained at scale to work on integrating the registry data. And I wanted to acknowledge the executive committee members in this project who are approving registry integrations. And then also go over our high-level method before we get to the AI. So from the associated registries, there are 22 data dictionaries that have over 15,000 variables. And then the experts on our executive committee and their teams help build a common data model, which is just harmonization and summation into common variables. And this is manual. So now we're asking the question, can we use an AI application to improve the platform with the addition of new data dictionaries? And this involves a data ingestion. And then after we complete this AI task, we need to do a data ingestion where we populate this with data from multiple registries. So here's some preliminary data that we've analyzed the registries with Jane's group. And this is just a similarity analysis in this heat map across all registries. So white means there's no concordance on the pairwise diagonal. And a darker red cell means that the registries have more common shared features. So each registry is matched with itself on the diagonal, showing perfect concordance. So essentially, there's very little in common across any of these registries, except for a few rare standouts. And on the right, I've shown a dendrogram of registries showing their dissimilarity. So the vision for us is to build a global registry, as I mentioned, and that so after we get consensus of these common manually annotated elements, we need to build a common data model. So we built a catalog of the 20 plus registry data dictionaries, and then we use a data structure in computer science called a directed acyclic graph. So this just means we're looking at the hierarchy of information. So a parent concept can go to multiple child concepts. So in the gene ontology, uh, cell, cell wall would be a child concept of cellular component, and you can only move one way. So there's actually an existing standardized graph data structure called the SCDO in sickle cell disease that we harmonized. And then we want to build a tiered common data model that we have different number of variables for different tiers for different clinical specifications that get more and more complex. And then we want to ingest all of this data with an AI-assisted federated ingestion. Uh, we take these 15,000 variables and group these into tiers. So uh, for the AI ingestion, we grouped raw variables into 312 concept subgroups across 5 categories, then rated these on both their importance and feasibility and sorted into 5 priority tiers. And so our 5 categories for sickle cell were diagnostics, disease, therapeutics, personal attributes, and then quality of life and care. And that tier 1 is the 45 must-have subgroups, and then each tier adds depth for richer settings. So uh, the bottleneck computationally and in terms of manual curation is harmonization at scale. How do we map thousands of variables by hand? We need to use AI foundation models. So this is our preliminary pilot where looking at the full SCDO ontology, we've begun to map 500 entries from the full therapeutic subset, um, and that the scale of the data across the 23 participating countries in the consortium is large and still growing. So curating it by hand is slow, costly, and impossible to sustain. And so uh, this work was built by Lucy Pham, a PhD student in my group, that she has made a 5-stage large language model foundation model framework to integrate sickle cell registries with the SCDO. So for each variable, the model proposes a path through the ontology, and then the large language model judge decides and does programmatic checks to verify it within manual curation from the sickle cell experts in the consortium. And so this is a basic framework today. Uh, my computer is having slide issues, sorry. Uh, so the first step we do is an enrichment phase, in that we ingest forms with the questions that patients are asked in each of the 23 countries. And then we use those to map an ontology on top of the SCDO. And then the large language foundation model picks the best match or rejects. And then as I talked about with the machine learning model grounding in the ontology context, we begin to ground these. We don't want hallucinations to affect our clinical reasoning or integration. So we do 5 programmatic checks outside of the foundation model to verify structural soundness. And then we route the unresolved cases to human review. And so we can think about AI error in different ways and how we fix them. So the first example is missing context. And so the AI model sees only a short description of the data without the original form from the country contributing data to the registry. It can't say which surgery a field means. So the fix is to ingest the original source forms, and that this is an enormous computational challenge, and that these forms are in different languages with different file formats. Some are nicely structured Excels, some are PNGs, some are PDFs. So we need to use vision language foundation models that can parse uh, different data modalities to solve this problem. We also have label noise. So in these sickle cell registries, similar variables appear under different names with inconsistent definitions and uneven specificity. So the fix here is to standardize labels, and we can build a curation UI to integrate the LLM judges in the foundation model work with the downstream human annotations. And then we also have, and I'm going to uh, classify the rate at which each of these errors occur. We also have AI limits. So we have occasional hallucinations or a key cue that can be missed. So these are familiar addressable model failures. So we can think about fixing this with bigger models that are trained on more data, specific prompt engineering for the LLM judges that we're building from our sickle cell foundation models, or a technique called expert RLHF. So once we have uh, AI foundation models trained from the sickle cell disease ontologies, RLHF is a machine learning method that stands for reinforcement learning from human feedback, where we tune the model's responses to be more uh, similar to the expert SCDO curators, the curators familiar with SCDO in the consortium. Uh, and so the AI that we've deployed still has problems, and that uh, our approach needs valid ontology paths in the SCDO, the sickle cell disease ontology, and that in pre-processing, we had to filter entries that wouldn't resolve. Uh, and uh, from our therapeutics baseline, this is the performance of the AI foundation model for sickle cell registry integration from each of the 5 paths that I defined in the previous slide. So we start to take all of our records from these forms we've ingested in many modalities. Uh, We have our mapping where we use sort of a graph data structure to map the form labels to the existing sickle cell disease ontologies. Then we have the LLM judge rank candidates. And then we have the sort of structural grounding to make sure that our clinical reasoning is correct, and then the outcome. And so we're doing sort of a blinded reader study to evaluate this, and that we see that the AI model gets all of the form elements correct in green, and that in orange and purple we have curation issues that are related to human curators that the AI picked up on, and that then in red we have the AI error. So the AI error is currently less than the human error in terms of building these registry integrations at scale. So now that we've evaluated that, we're beginning to ask what's next. So in the next 3 years, we're planning to harmonize the full catalog from all registries, build a pipeline and curation UI, finalize tier 1 in the next couple of months, integrate source forms, scale models, and then begin to think about how we can deploy this globally, build AI-assisted reassessment and updates, think about an ICD-9 to ICD-10 style evolution, and then integrate this into guideline specifications for treatment planning like ARIA. So our vision is a living, learning, AI-assisted sickle cell registry for the world, where we have a global network that the Worldwide Clinical Alliance supplies the data. We provide the AI harmonization. The model we've built maps it to one standard, and then we have shared evidence so that fragmented data becomes comparable insight. And so our goal is that to provide specialized, compassionate care with these resources and a long, fulfilling life for every young person with a catastrophic blood disorder everywhere it occurs. So I'd like to thank all of my collaborators on the top half of this slide, as well as the postdocs, PhD students, master students, and undergrad students in my lab. Uh, and I want to give special thanks to the I3 section in radiology, Lucy, Paul, Pritam, and Andrew at St. Jude, and then also the St. Jude Global Hematology Program. And I'm very grateful to our collaboration with the Script Consortium, with Deepa Mamwani, and then my lab's collaboration on this project with Jane Hankins, where we've essentially provided all of the AI expertise, and she's provided all of the sickle cell expertise. And then the other members of the St. Jude Global Hematology team, Nick, Benny, Tessa, Katrini, Sarah, and Renee. And then our global partners, the WHO, ASH, Africa CDC, NCDI, CHAI, UNICEF, and Sickle in Africa. So thank you, and I'll answer any questions.
Thank you so much, Professor Luber, for the excellent presentation and the groundbreaking AI integration in hematology. I don't see any questions for you, so thank you so much for joining us today. We move to the next speaker. Our next speaker is Dr. Saleh Ashurafa. Dr. Saleh Ashurafa is a senior consultant in pediatric nephrology with significant leadership roles in regional professional societies. He is a founder and a past president of the Arab Pediatric Nephrology Association, as well as a founder and a former president of Saudi Hypertension Management Society. Dr. Ashurafa serves on European, Middle Eastern, and Asian advisory boards and has authored numerous publications, contributed chapters to pediatric nephrology books, textbooks, and acted as the chief editor of the Saudi Hypertension Management Guidelines. اتفضل دكتور.
Assalamu alaikum. Good morning. Can you hear me?
Yes, we do.
I need to share, but if you allow me to share, please, because I don't think I'm allowed to share here. Dr. Najat?
You can share your slide, doctor.
I can share. Okay.
As a panelist, you have the function to share. Just you find any three dots like more.
Yeah, I
You
went
see
to,
share like
yeah, I went to more, and then I found cancel. Share is not apparent.
just a second.
Maybe I will allow you to enter to my laptop if you can. Let me go to setting, maybe. Maximum video chat video. Can you?
You will find an you see the word of share.
I see the word faded share only. Maybe.
Let's do one thing. Just open your slide and try to put share. It's open and window or not giving you the function.
Now I open my slide, my dear. It's opened already.
Okay. Try to put share. By default, I cannot close or stop your share from your end because I give you the full function.
And share entire screen, also share system audio, and
Yeah, if you see this menu, you just select your presentation from this window.
I cannot share, my dear. I don't know why. So
Let me do one thing. I will assign you as a co-host. So you are now co-host. You have the full function.
let me, I will tell you one thing. Let me go out and then I will re-enter if you don't mind.
It's okay. If you wanted to share your slide with me, I can write my email. I give you the full control from my side. You can control your presentation from my end.
Or I will enter through.
It seems Dr. Salah has a technical issue. Just a couple of minutes, we will make sure that he.
بعد عندي كلينيكال طالع تعال انا بعد اليوم عندي دمار ما ادري شلون طلع هذا عشان وش طلع ما عرفت اشيله. أوكي.
تقدروا تسمعوني؟
نسمعك دكتور.
أنا
We can hear you clearly.
أرسلت السلايدز إلى
I will
دكتورة
share
نيلا.
your slide now.
Yes, please.
Okay, I give you the control.
Okay. Bismillah.
You are
Is it
able
okay
to
now?
control the slide. Just,
Yeah. Is it okay now?
just allow me to mute myself, then you can control your slide, okay?
Okay. Okay, good morning, everybody, and happy Eid. كل عام وانتم بخير وسعادة. I would like to thank the organizing committee to give me this opportunity to share with my best friends, hematologist. I am Saleh Al-Shurafa, pediatric nephrologist, and I will discuss today the modern approach to pediatric thrombotic microangiopathies, focusing on TTP and HUS. Do you hear me well?
This doctor, please. Yes, you're
Yes.
okay.
Okay. The major challenge is that the organ injury can progress rapidly. The key message is very simple. Time is organ function, and early recognition and targeted therapy have dramatically changed the outcome over the last decades. Now, previous slide. Okay. As you all know that previously 90% of TT patients carry a mortality. So mortality was very high, but with plasma therapy, it had been reduced to 10 to 20%. 1 to 4 per million cases of TTP below 18 years, which represent around 10% of all TTP cases. So hereditary patients who develop major morbidities like stroke, kidney injuries, cardiac injuries, these constitute of 34%. In HUS, they carry morbidity and mortality in 75%. Only 25% they might have minor organ injury like proteinuria, hypertension, etc. So HUS patients developing long-term renal insufficiency, GFR below 80, dialysis previously more than 2 to 3 weeks is a strongest predictor of chronic kidney disease. So congenital TTP and HTEC, which is sugar toxin, HUS, dominate the pediatric landscape, and mortality and lifelong morbidity profile demand immediate action. So now we will move to pathophysiology, which is a tale of two pathways, TTP pathway and HUS pathway. TTP pathway is through Adams TS13 deficiency, while HUS pathway is through complement dysregulation. So TTP, what is the triggers? Triggers is the mutation of congenital TTP or IgG autoantibodies in immune thrombocytopenia. And the mechanism is the Adams TS13 actively below 10% or very, very low or zero. And that will lead to an cleaved ultra-large Van Willebrand factor, which lead to endothelial injury and platelet aggregation and microthrombi in all small vessels. So it can affect all organs and not only neurological organ as we classically knows. HUS in other part through a shigatoxin, which is not really dominant now in our area, but we have the ones through complement dysregulation, which is chronic, and through deficiency of inhibitors, genetic variants like CFH and factor I, MCP, factor B, and C3, which is constituted of AHATs. And the mechanism is through uncontrolled C5 activation, which lead to endothelial lysis and glomerular thrombosis. The team A triad in both, but in here there are more. So microangiopathy, hemolytic anemia, MAHA, severe thrombocytopenia, ischemic organ injury, which is mainly brain, kidney, heart, but can affect all organs. So now, we will move to, why like this? Okay. Let's move now to diagnostic matrix, how we differentiate between congenital TTP or immune TTP. ITP might be confused by some residents, and hemolytic uremic syndrome and DIC. If we look to coagulation profile, in DIC, the child is so sick, infection, he has a usually infection with prolonged PT and PTT, while all are having normal PT and PTT or slightly prolonged, which is not really significant. In TTP, they have either absent in congenital TTP or very low, or severely decreased below 10%. While in hemolytic uremic syndrome, it's minimally decreased, but usually is above 70%, 80%, like this. So the key here, for TTP is decreased hemoglobin, high LDH. This can be done in emergency room. And later on, if you assay Adams T13, you can either see that there is an absent or low Adams T13. In ITP, it's isolated low platelets, but without any affection of Adams. And HUS, it's either shigatoxin positive, which can be done in 30 minutes if you have it in your hospital, or if Adams is normal and normal PT, PTT, and no shigatoxin, then that recall AHUS, or atypical hemolytic uremic syndrome. The primary treatment, either by recombinant Adams, which is replacement therapy, or plasma therapy plus steroid plus the new therapy, which is cabazizumab. In ITP, this is totally different mechanism. We can just give IV immunoglobulins or steroid. And HUS, the classic first line is eculizumab now, and it is replaced gradually by ravulizumab because it has longer half-life. In DIC, of course, you treat underlying cause. So normal or minimally decreased Adams TS13 redirect diagnosis entirely toward HUS or DIC, but never delay plasma therapy while awaiting the result. So what is the breakthrough I'm sorry for the disturbance because I'm not really expert in modifying or doing this new era of, computers. And in fact, I prepared, renal complications of sickle cell as emailed by Dr. Najat. So I prepared it very well. But last night when I came back from my travel, I found the schedule, which is different. So I prepare it with the help of AI. Help of AI does not change my wordings at all, only make the design of the slide, but it changed it, too much. Anyway, this is in New England, the Journal of Medicine, 2024, about the recombinant Adams TS13, which is FDA approved in 2023. It is targeted enzyme replacement for congenital TTP, which replace the usual classic way of treatment, and it is safely achieving physiological Adams TS13 level with zero neutralizing antibodies. So in here, they compare standard therapy, and they achieved 19% achieved the level, while with recombinant therapy, it's 101%. And the thrombocytopenia, as you all see, you can achieve it. You can achieve normalization very quickly. So the breakthrough of cablasizumab in pediatric immune thrombocytopenia, as you all see, this is Vanual brand, which is very large molecule. And this might cause endothelial injury and lead to platelets aggregation and thrombocytopenia and all the rest of signs and symptoms you are seeing in your clinical practice. With this therapy, through the anti-Vanual brand nanobody, it blocks. So when it blocks this, there will be rapid platelet response within 48 hours. And the dosing, as I see with my hematology colleagues, they usually start with 5 milligram daily in patients below 12 years or below 40 kilograms. But in patients more than 12 years, they usually start, like adult colleagues, 10 milligram daily. 10 milligram IV loading the dose in day one, then sub-Q administration until they achieve Adams of more than usually 20%. And this is very well studied, and a lot of literatures now showing full response rate in minors, supporting systemic use of this cablasizumab and rituximab. So AHUS, it's uncontrolled complement activity, which might lead to devastating consequence. So this is the classic and alternative pathway between when we shift from C3 to C5. C5 is always active. It's like when you want to kill bacteria by a fire, but when you cannot put the fire off, it will burn yourself. You will burn yourself. So through these natural inhibitors like factor H, factor I, factor B, MCB, etc., you can put this fire off. So you kill the bacteria, but you don't harm yourself. And this is what exactly happening with the eculizumab. This is the new therapy which was introduced. We used it since 2011, which has really changed the prognosis and organ injury and the transplant era from killing disease to treatable disease, hemolytic uremic syndrome. Ravulizumab, people start using it since 2020, and now we are replacing the eculizumab with this because it has longer half-life, and the dosing we are giving is every 8 weeks, except in few patients we decrease it to every 6 weeks, and only one patient every 4 weeks, and it is really, really, really effective. So the 2026, this is multi-node inhibition through messenger RNA in hepatocytes. This is one of the drug which is first in class, oral factor B inhibitor. Now it's almost finished phase 3, and they enter to phase 4. And this might eliminate IV infusion, which is by eculizumab or ravulizumab. And this is another therapy that target C5 messenger RNA in hepatocytes also. So there are two companies are working on this to shift from IV infusions to oral therapy. So there are multi medications which is shifting from intense hospital-based IV therapies to manageable weight-based oral protocol for children. So the gene therapy and personalized medicine now, Adams TS13, mutation analysis and complement gene, CFH, CFI, MCP now actively dictate therapy selection and the duration, replacing one size fit all. And also this is targeted delivery with Adams T13 expression via liver targeted messenger RNA. This hardless remaining are immune reactions and expression durability from congenital TTP. The biomarkers monitoring also, Adams TS13 activity, we use 10 to 20% activity threshold to safely discontinue the cablasizumab, which is really very expensive therapy. The cost in Saudi Arabia, I don't know how much is the cost in your countries, is around, between 28 to 32,000 riyals per dose. That will give you around 3,000 Bahraini dinars. And this is also direct real-time monitoring of complement inhibitor efficacy. Now, when we admit patients to ICU, the step one, we need to really act is to suspect TMA. If we suspect TMA by MAHA and thrombocytopenia and organ injury, any organ, usually the either brain or kidney or heart or GI or vessels or pulmonary, because these are all affected. I don't want to make things complex, but when you suspect, you take Adams TS13 and you take smear and you take coagulation profile, which will be normal. If Adams is below 10%, then TTP, then you do immediate plasma therapy, and you might give IV steroid. Then you add either rituximab or cablisizumab, and you monitor the activity daily if you have it, or at least weekly if you don't have to send out to other laboratory. If you have this, which is more than 10%, you immediate give eculizumab or ravulizumab. But let me tell you one thing. Now we depend much on scoring system, and we decide even before we get Adams level to start early eculizumab or ravulizumab, whatever is available in your hospital. And we do workup through coagulation, CBC, etc., blood smear, and component levels, and CFH antibodies, genetics, and we monitor. If it is normal and STEC positive, then we do supportive care. We don't give antibiotics, do not give it, or antimotility. Previously, we do dialysis, but for the last 8 years, we are just giving eculizumab, and usually they require 2 doses, and that's it. So it is replacing hesitation with mechanistic precision. You start your therapy immediately, and you don't wait for confirmation. So now we really are shifting from survivorship to prevent organ injury. So mortality issue, raised with every hour of delay. So you need to initiate your therapy through plasma infusion or through the therapies I mentioned. If you suspect HUS, you start eculizumab, and TTP survival, it's mandatory to do annual and screening for autoimmune disorders like SLEs, Sjogren's, for patients above 12 years. And you monitor, anti-double-stranded DNA and anti-SSA. For AHUS, also you do genetic counseling, you do strict kidney function monitoring, and risk stratified therapy to decide about discontinuation protocol, because therapy is really expensive, which costs in Saudi Arabia around 1.8 millions per year per patient, 1.8 million riyals, which is around 180,000 Bahraini dinars. So, and universal protocol for both. You do annual blood pressure, urine analysis, GFR, and plus the hematology workup to be sure that you are safe. The 2026 paradigm that we have to speed up workup, to initiate treatment before full workup, because hours dictate survival. And we use recombinant Adams TS13 to make it 0 acute events, and to have physiological activity which is good enough to prevent organ injury and to prevent mortality. And we can use cablisizumab. It is safe, effective 5 milligram of label, and it is FDA approved and Saudi FDA approved with 100% response. In HUS nowadays, we use ravulizumab. We don't use eculizumab. Maybe one or two centers only in Saudi Arabia still using it. And we use it every 4 to 8 weeks dosing. And that transforms quality of life with up to 90% complete response. So no organ damage and no mortality. Now, there are a lot of work in oral factor B inhibitors and siRNA, which are actively dismantling infusion burdens. The true precision, really, now we treat based on Adams TS13 activity and complement genomics, not just the clinical syndrome. So we shift from thinking of a syndrome to treat pathophysiology. Now, if there is time, I will go to show you some cases. This is one of the cases with large visual complication. And this is HUS patient. We treat, but you see how the thrombi, I don't want to take time. These are the fingers, which are almost amputated. This is the patient, and after eculizumab, you see how the hand is saved because our vascular surgeon decided to amputate, and we had, I remember, a big fight not to amputate. So we put the therapy, and that's the result. I think I'm going to stop here, and I expect questions. And thank you very much, and I hope I make it so simple. Thank you.
Thank you so much, Dr. Saleh, for the excellent presentation. There is one question for you. In a patient with progressive acute renal injury, would you consider doing Adimetas 13 or complement panel?
Progressive kidney injury have, as you know, a lot of causes with the progressive kidney injury. But if you have the triad, which is MAHA, thrombocytopenia, and renal injury like severe AKI or any other organ injury, yes, that recall doing Adams TS13 to differentiate between MAHA due to TTP or due to HUS. Then that is almost mandatory. Usually, the company which is supplying you the therapy are helping to do that if you don't have lab to do the level. But, as you know, now also there are scores like plasmid score or a French score. Plasmid score, if you have, platelet count less than 30, retics more than 2.5%, with no active cancer, no stem cell transplant, MCV below 90 flow liters, INR, which is less than 1.5, and creatinine below 2, that will support TTP. So what you do, you start therapy for TTP while you are awaiting the results of Adams, or if you don't have, just start your therapy and do not delay the therapy because it is really crucial to prevent mortality and organ injury. Some of countries are using French score. French score is so simple. They depend on a platelet count. If platelet count below 20,000, not 30 like plasmic, and creatinine, which is normal or below 2, and having evidence of hemolysis like high LDH. If you have a score more than 2, which is indicating high TTP probability, you start your therapy for TTP. If you don't have these scores, you have MAHA, and you have thrombocytopenia, and you have acute kidney injury with negative Shiga toxin in small kids. Usually it is HUS, which we have it in the Gulf, more than Shiga toxin associated hemolytic uremic syndrome. We immediately start ravulizumab or eculizumab, and then we see whether there is a really response or not. Usually the response is almost 100%. And Shiga toxin associated, if we have it, usually we require 1 or 2 doses. That's it. In AHUS, no, we require 6 months to 1 year, then we re-evaluate to stop the therapy or not. Did I answer your question, Doctora?
Yes, thank you so much, Dr. Saleh, for the excellent presentation. Now we move to the next speaker. Our next speaker is Professor Paul Monegal. He's a professor of pediatrics, University of Melbourne, co-group leader, hematology research, Murdoch Children's Research Institute. He's a legendary figure in pediatrics hematology. Professor Monegal formerly served as the Stevenson Chair of Pediatrics and Head of Pathology at the University of Melbourne. His work continues to define global standards in pediatric thrombosis and laboratory medicine. Welcome, Professor Monegal.
Thank you very much for the introduction, and I hope you can hear me. And I will just share my slides. Okay, so you can hear me and you can see my slides?
Yes, we can hear you and we can see your slides, yes.
Thank you so much. So thank you very much to Dr. Najid and the rest of the organising committee for asking me to be with you all. Good morning to you. It is late afternoon, early evening here in Melbourne. And today I'm talking to you about paediatric thrombosis, recognition and management of a silent epidemic. I have no financial disclosures to declare. I am on the have been on the steering committee of a number of the DOAC trials or have enrolled patients in them. And my research team has received some support from a number of different organisations, but I don't think any of them will dramatically change what I'm going to say today. So, reminding us that the epidemiology of thrombosis in children is very different to adults. And you can look at the thrombosis rates related to orthopedic surgery, to conditions like nephrotic syndrome, or even in malignancies. And you see that the rates of thrombosis for those kinds of conditions are very different between children and adults. The main driver of thrombosis in children has been the improved survival of sick children, and it's now recognised that hospital-acquired VTE is the second largest cause of preventable harm in paediatric hospitals. VTE in the general population in paediatrics is rare, about 0.07 per 10,000 children. But once you actually move into a hospitalised population of children, that rate goes up by 100 to 1,000 times. The most common precipitating factor is the presence of the central line, which is related to about 80 to 85% of paediatric VTE. But pleasingly now, there have actually been 3 anticoagulant drugs that are now approved for use in children by both the FDA and the EMA, and I'll come back to those later. I want to just say a couple of things about diagnosis first. Remember that in adults, the most common form for diagnosing DVT is an ultrasound. And ultrasounds are very sensitive for DVT in the lower extremity, and they are less sensitive for asymptomatic thrombosis compared to symptomatic thrombosis. However, even in adults, when you move to the upper extremity, which is where most clots in children occur, ultrasound has much more problems with sensitivity, especially for the asymptomatic thrombosis. So, and that's because of the anatomy of scanning in the upper system versus in the lower extremity, where the clavicle and the ribs get in the way of your view of the venous structures. So the challenges for using ultrasound in children are access to vessels, the frequency of non-compressibility due to the anatomical location, and the potential, especially in very small children, for slow flow to mimic no flow. There's also issues around compliance with the study, and clearly there's an operator dependence. PE has historically been very poorly diagnosed in children. I will say that over recent years, with the increasing use of CT and MRI, we are now getting better at diagnosing pulmonary embolus in children than in the past, but it is still probably an under-recognised entity within children, although with better diagnosis, we are probably reducing the mortality associated with PE in children. So reminding everybody that venous thrombosis in children is a radiological diagnosis, but that achieving that diagnosis is often difficult. While the D-dimer has very useful negative predictive value in adults, most of the studies in children have actually shown that it does not have the same value in children, and that is not surprising given the epidemiology and that the bulk of children who get VTE have underlying illnesses and are hospitalised. So D-dimers in general should not be used as part of a diagnostic workup for VTE in children. The other point that I just want to make is that thrombophilic tests should never be used as part of the diagnostic workup. The presence or absence of a congenital or acquired thrombophilia marker does not prove or disprove the presence or absence of a thrombosis. That can only be done with a radiological test. So thrombophilia testing has very limited role in paediatric VTE. We do see acquired thrombophilia more commonly than congenital thrombophilia, and it may be useful to test to understand the etiology and the potential recurrence rate, especially in children with spontaneous VTE and clearly in neonates who might have purpura fulminans. But there are many pitfalls to testing, and as I say, the important thing to understand is that you cannot use the presence of a positive thrombophilic test to prove or disprove the presence of a thrombosis. So in summary, in terms of diagnosis, I just want to again remind us that thrombosis is a radiological diagnosis. Lab testing has minimal role in the diagnosis. It may have a role in understanding the pathophysiology, for example, the presence of an antiphospholipid antibody syndrome, but one needs to be really carefully interpreting the results, and rarely do those results change the immediate management of the patient. The lab is critical for monitoring anticoagulation in children, but that's something we could talk about another time. So in terms of management of VTE in children, I want to just remind everybody that the American Society of Hematology and the International Society of Thrombosis and Hemostasis work together to provide the 2025 updated guidelines for the treatment of VTE in children. And this is now probably our gold standard guidelines for the treatment of VTE in children. Interestingly, compared to the 2018 guidelines, these guidelines backed off a little bit on the certainty of treating symptomatic DVT or PE in children. And that really comes down to the issue that there are some children with DVT and PE, and the specific papers that led to the softening of this recommendation were the trauma-related papers, where the bleeding risk actually outweighs the thrombosis risk. And so, as always, the decision to use anticoagulation needs to be based on a weighing up of the risk-benefit ratio for the individual patient. But in general, most patients with symptomatic DVT and PE require anticoagulation. That's different from what we call clinically unsuspected PE, which was previously termed asymptomatic DVT or PE, where the guidelines suggest either using anticoagulation or not using anticoagulation. And that's primarily driven by the fact that the natural history of clinically unsuspected DVT and PE appears to carry a much lower risk of acute and long-term sequelae in certain paediatric subpopulations. So the best study that's been done, of course, is the Sophie Jones study that looked at children in intensive care post-cardiac surgery. And although 20 to 25% of the children developed asymptomatic thrombosis that was detected on routine screening that was blinded, kept from the clinicians who were caring for the children, and those children did not receive any therapy for their asymptomatic or clinically unsuspected VTE, and their clinical outcomes were no different from the group who did not have VTE. However, what we don't know is whether those principles apply over all the different populations of children who can have unsuspected, clinically unsuspected DVT or PE. Thanks to the KIDS study, the guidelines now recommend suggest 6 weeks rather than 3 months of anticoagulation in select paediatric patients with provoked VTE. As I say, this was largely based on the KIDS study, and there were specific inclusion and external criteria in that study. So the patients excluded from this recommendation are those with pulmonary embolus, cancer-associated VTE, recurrent VTE, persistent provoking factors, or major thrombophilia. And if the child has a repeat ultrasound or imaging at 6 weeks after treatment and the clot has either become non-occlusive or has resolved, then it is reasonable to cease treatment at 6 weeks. If, however, the child has any of those excluded factors or has ongoing risk factors such as persistent antiphospholipid antibodies, or if the clot remains persistent, then those children should go on and receive 3 months of therapy. Some of the other important guidelines in this in this lot of recommendations were around the use of DOACs, and the panel suggests using DOACs over standard of care anticoagulation in children with VTE. This is based on 3 large RCTs, 2 large multi-centre trials and a single institution study, with almost 853 patients recruited to the studies, in whom over 500 received a DOAC. So we now have more published data on children who have received DOACs than we do on children who have received standard of care therapy. Remember that in those trials, the children that were excluded from the trials were those with severe liver or renal impairment, preterm neonates and infants that were very low weight, and those who had active bleeding and high risk of bleeding. The other important thing to remember in all of the DOAC trials for VTE treatment in children was that all patients received a minimum of 5 days of a parental anticoagulant, usually either unfractionated heparin or low molecular weight heparin, before they started the DOAC. So unlike the adult trials, there have been no studies in children that have addressed whether or not you can commence a DOAC at diagnosis. All of the studies used at least 5 days of a heparinoid prior to the introduction of a DOAC. And the recommendation that, or the suggestion that we use a DOAC over standard of care was based really on the lower rates of thrombus recurrence, but with also no difference in mortality, thrombus resolution, or major bleeding or clinically relevant non-major bleeding. In terms of the individual agents, there are published studies for VTE treatment in children using rivaroxaban and dabigatran, and individually the ASH-ISTH guidelines suggest that you could use either of those drugs over standard of care, but they did not find any benefit or any way that they could recommend one of those drugs over the other one. So basically, you can either use rivaroxaban or dabigatran for the treatment of VTE in children. As yet, there have not been published studies on the treatment of VTE in children using any of the other DOACs, such as apixaban or edoxaban. While those studies have been conducted and some have been presented at conferences, they have not yet found their way into publication. So that's why the recommendation was to use either rather than to prefer one over the other, recognising that in individual patients or depending on the setup and the funding mechanisms in your jurisdiction and the availability of the paediatric preparations, all of those factors may be involved in helping you choose one agent over the other. The cohorts in whom we do not currently recommend using DOACs because we don't have published data for it in children: antiphospholipid antibody syndrome and mechanical valves. Clearly in the adult trials, the DOACs were not particularly effective. At the minute, there's not a lot of published data, although there's just been a very small case series published out of Sydney within the last couple of weeks of some children with short gut syndrome who have received apixaban and done reasonably well. Recent surgery, severe liver disease, renal disease, preterm neonates, and patients with active cancer. So in summary about the DOACs, we can use them after 5 days of initial parenteral treatment. Either rivaroxaban or dabigatran can be used for treating VTE, but there remain some cohorts of children that we do not recommend using the DOACs. Anticoagulation is suggested for most paediatric patients with symptomatic DVT. For asymptomatic or clinically unsuspected DVT or PE, the benefits and harms of anticoagulation vary, and whether or not anticoagulation should be offered needs to be individualised. There's a lot more research to be done to help us understand the natural history of clinically unsuspected VTE and the harms of treatments in specific subgroups. I do just also want to mention that in 2026, earlier this year, ASH and ISTH also published their first prophylaxis guidelines for children at risk of venous thromboembolism. In terms of paediatric VTE prophylaxis, we are essentially talking about hospitalised children because that is where VTEs occur. Remembering again that VTE in children has a complex pathophysiology, and children have very distinct thrombotic and bleeding risk profiles that are different to adults. Any strategies need to be age appropriate and cannot just be extrapolated from adult studies. And there remains a lot of work to be done to develop appropriate strategies across all of the age groups. There were two really overwhelming principles that the ASH-ISTH panel considered when looking at the VTE prophylaxis guidelines. And the first was that in thinking about whether or not to offer a patient prophylaxis, you not only need to consider their risk of thrombosis, but also their risk of bleeding. And the main principle that the panel considered as it approached its recommendations was a first do no harm principle. The risk-benefit ratio of anticoagulation prophylaxis in children needs to be assessed on an individual basis and should be reassessed regularly because the children clearly change during the course of their admission. The second overwhelming principle that the panel wanted to emphasise was that when you do have children on thromboprophylaxis, most paediatric hospitals are not used to anticoagulation, and therefore you need to develop very strong institutional guidelines and practices and documentation procedures to make sure that appropriate peri-procedural interruption of anticoagulation happens, and that children are not placed at risk, especially when they are having lumbar punctures or spinal anaesthetic procedures due to prophylactic anticoagulation. So that's a really important thing for people to remember when they're trying to operationalise anticoagulation in their own hospital. In terms of specific recommendations around prophylaxis, we looked at two major trials for the ALL group who were on asparaginase, had central lines, both the Thrombotec trial and the Prevapix trial of apixaban. And whilst there was some potential benefit in both studies, there was also some potential risk. And so the panel felt that it could not suggest that the treatment should be given. So it said that you could either anticoagulate or not anticoagulate, and either option was reasonable. In part, the patient population was way too heterogeneous with regard to both their VTE and their bleeding risk to make a general recommendation. There appear to be some subpopulations who might benefit more from anticoagulation, and those include the teenagers, especially those who are obese, have T-cell immunophenotype and high or very high risk ALL, and a prior thrombosis or prior history or family history of thrombosis. In terms of the common factors that increase the risk of thrombosis for these patients, it was asparaginase and their central line. And so if you are going to offer prophylaxis, you should only do it during the asparaginase containing cycles. We were very clear that we did not see any benefit to giving antithrombin to these patients. If you wish to give them something, it should just be straightforward anticoagulation, and that was primarily based on the Thrombotec trial, where there was reduced event-free survival in the children who received antithrombin. Home TPN, so children who are requiring TPN for greater than 60 days, was a group in whom we did recommend or suggest appropriate thromboprophylaxis. And that was based on the fact that given their lifelong need for vascular access and the life-threatening consequences of losing vascular access, then there may well be some benefit to anticoagulant prophylaxis, and the bleeding risk appeared to be small. In terms of critically ill children, the panel considered the CRETE randomised trial, which reported a reduced risk of developing a central line-associated VTE in critically ill children who received thromboprophylaxis. But we noted that only 2.5% of all screened patients with a CVAD were ultimately randomised. And over 60% of the screened patients were deemed ineligible due to their high risk of bleeding. And then some of the children who were randomised to receive enoxaparin actually did not receive the intervention. So while we felt that this study reported a positive result in favour of anticoagulation, we did not suggest universal anticoagulation prophylaxis in critically ill children, but consideration of some specific subgroups who may benefit, whom are at a high risk of VTE but a very low risk of bleeding. Finally, I'm just going to briefly mention the paediatric DOAC programs. Dabigatran and rivaroxaban have essentially completed their programs now, and those two drugs have been approved in both Europe and the US. Edoxaban and apixaban have completed some phases of their programs, but have not published their VTE treatment data as yet. Excuse me. In terms of the indications that were covered in those trials, VTE primary and treatment and secondary prevention were covered. There was a fair bit of work on the cardiac group for apixaban, edoxaban, and rivaroxaban, and only one study looked at primary VTE prevention, and that was in the ALL lymphoma central line asparaginase group. What are the conclusions that we can make from the DOAC pediatric programs? In general, they are well-tolerated drugs. We achieve similar drug exposures to adults, and they have favourable clinical efficacy and safety. We can use them for the treatment of acute VTE after initial heparinoid therapy. We can use them for primary and secondary VTE prevention, and some TE thrombosis prevention in congenital heart disease, especially the Fontan procedure. Understand that in these trials, the bulk of the children enrolled were older children and adolescents who were relatively healthy with only mild or moderate comorbidities. Younger age groups were underrepresented, and premature infants and those with severe comorbidities were excluded. And a number of the trials were limited to specific disease populations. And so whether or not the data is generalizable or not, we don't know. In general, certainly for rivaroxaban, we can say that routine monitoring is not necessary. It's a little bit unclear for dabigatran because in the diversity trial, a significant percentage of the children were excluded from the trial because they did not reach predetermined levels of the drug. And so therefore, whether or not you need to actually take levels in the initial instance remains unclear. Whether or not monitoring has a role in the populations that were excluded from the trials is unknown, and there is no pediatric specific data about drug or food interactions. Also remember that of the DOAC trials, all of the endpoints of the trials were acute. Recurrent thrombosis, thrombus resolution or progression, VTE-related mortality, major bleeding or clinically relevant non-major bleeding. There was no study that effectively looked at longer-term outcomes in terms of things like development of post-thrombotic syndrome or quality of life. But we can say that DOACs now, we have, as I said earlier, we have more published data on DOACs than we do on warfarin, heparin, low molecular weight heparin. I'm going to stop there and thank my team who have done lots of research over the years that contributed some of the data towards those guidelines. And I'll stop sharing my screen and I'm happy to take a question if you like.
Thank you so much, Professor Monegal, for the excellent presentation. And there's no questions for you. Thank you so much for joining us.
Thank you and enjoy the rest of your program.
Thanks so much. We move now to the next speaker, Dr. Mariam Aboushel, medical genetics consultant, Salmania Medical Complex, Bahrain, distinguished by achieving the highest score in her fellowship exit examination at King Faisal Specialist Hospital, Riyadh. Dr. Aboushel further honed her expertise with the clinical training at the Manchester Centre for Genomic Medicine, UK. Please, Dr. Mariam.
Good afternoon, everyone. I hope my sound is clear and my slides are clear too.
Yeah, they are.
Oh, thank you. So thank you, Dr. Najat and the organizers of this amazing conference. Today, my presentation, I will be discussing about a comprehensive view about what are the genetic syndromes or inherited conditions that can present with thrombocytopenia. So first of all, knowing I'm sure about this knowledge, but as a revision, what is the normal platelet count, which is expected to be seen in adults? It is around 150,000 to 400,000 per microliter. We will consider thrombocytopenia if it's below 150,000 and below 20,000, it will be considered as a severe type. So when we talk about what are the different etiologies behind thrombocytopenia, it can be either, number one, due to decreased production, either because of conditions like aplastic anemia, leukemias, radiation or chemotherapy-related side effects, or due to genetic conditions, and we will be going through some of them. other etiology can be associated with increased peripheral destruction, like we see in immune process, like ITP, TTP, like we have seen our colleague discussing it, HUS. Is it drug-related or is it some other autoimmune conditions? Or no, it is due to sequestration or different maldistributions, like we see in hypersplenisms or dilutionals and other, etc. examples. So let us go into one of the examples of congenital conditions that can present with thrombocytopenia is the TAR syndrome, thrombocytopenia absent radius syndrome. So the genetics behind TAR syndrome is that it is related with the gene, which is the RBMA, and this is located on chromosome 1. And what happens here, it is an autosomal recessive condition, but because of compound inheritance, means there are two different problems, let's say, in the alleles. One of them is a deletion. The other one is a pathogenic variant. And that's why this will cause a problem in the product of this gene, which is the Y19 gene. And this Y19 gene has a very important role in the exon junction complex. And because of the deficiency in this protein, there is a defective RNA processing, which will impair the megakaryocyte development and eventually causes thrombocytopenia. The same also exon junction complex can also cause a problem in the limb development, especially in the embryonic period. And that's why it was also associated not only with hematological, but also with skeletal problems, which manifest as bilateral absent radius. So if we will see about the clinical or key features, number one is the skeleton. The newborn will be born with obvious skeletal deformities, which is seen as very short forearm, which is because of the absence of the radius. And in addition, also it could be hypoplastic ulna. So when we do a skeletal survey, we can clearly see that there is an absent radius. But a very important point to keep in mind, a hallmark, is that the thumb is present. And why is it important? Because it helps us to differentiate with other radial defects syndromes. So in addition to the upper limbs, it can also seen in 50% also of the cases, not only the upper limbs, also we can see lower limbs deformities in the form of hip dysplasia or various knee or ankle deformities. As it can be seen, these are all examples from the internet. So you can see how these newborns manifest very early with almost, there is no forearms, but the thumb, as you can see, they are present. Because this will help us to differentiate from other conditions like Fanconi, like Coat Oram. So the thumb is the hallmark that is present. And as you see the X-ray, there is an absent radius. So they have very short forearm. So one of them is the skeletal manifestations. And if you take for them labs workup, you will find that they have thrombocytopenia. The thrombocytopenia can vary. They can have mild to even severe thrombocytopenia. They usually manifest early in the neonatal life, either at birth or soon later. So this will keep them at risk of bleeding, whether intracranial hemorrhage, GI bleeding. They can present with petechiae, easily bruisability, epistaxis. And it has been noticed that this is very easily triggered by infection, any type of stress. So the platelet, the hematological count is usually most severe during infancy, and it has been observed that it improves with increase in age. A very important also thing, features that have been seen associated with the TAR syndrome is that the newborns, they manifest with also manifestations of cow's milk intolerance, vomiting, diarrhea, severe eczema, failing to thrive, the usual manifestations of the cow's milk, but it's also considered as a stress-related conditions, and that's why it has been noticed that it causes worsening in the thrombocytopenia in such cases. And if it is well managed, there is an improvement in the platelet count. So this should be addressed. In addition to the things we have manifested, other clinical features can be congenital heart disease, can be renal anomalies, genitourinary anomalies, and to keep in mind, these cases usually have normal intelligence. There is not associated with neurodevelopmental problems. If we will take lab, as we mentioned, the CBC, it will show isolated thrombocytopenia, which is, I think, is a very important thing to keep in mind. And also, as you know, in the CBC, it's very important for us to differentiate between the syndromes, not only the thrombocytopenia, even the size of the platelets. So in TAR, the usually platelet size count is normal, unlike in other syndromes, which we will see again. So what kind of diagnostic workup when you will see such cases? You will do a CBC, you will do a skeletal survey, an echo, and as we mentioned, to rule out the other anomalies, you will screen. A very important point to keep in mind, what type of genetic testing is required in such cases, as I told you in the first thing, is that it is a deletion in one allele and a pathogenic variant in another allele. So you have to make sure that the genetic test that you request can include to detect the deletions. Otherwise, it can be missed if it is only sequencing without detecting the copy number variant. How you will manage such cases, as we mentioned, in the neonatal period, because of the risk of bleeding, closely monitor the platelet counts, platelet transfusion if necessary, to avoid the severe manifestations. And definitely the long term, it will require multidisciplinary team involving definitely the orthopedics, the physiotherapy, avoiding unnecessarily antiplatelet medications, example aspirin, manage the cow's milk intolerance, and keep on following with the multidisciplinary team. Usually they have, from hematological point of view, they will have good prognosis, their platelet count will improve substantially, and their life expectancy is expected to be normal. Moving on to another very important syndrome also is the Wiskott-Aldrich syndrome. And this is an excellent mode of inheritance. It is also considered type of an immune deficiency disorder. The main classical trait of this syndrome is the microthrombocytopenia, the uncontrolled chronic eczema, and recurrent infection. So the genetics behind this syndrome is the WAS gene. And because it is X-linked, we said it is located in the X chromosome. So as we all know, it will be mainly affecting the males. The females will be, most of them are asymptomatic carriers. This WAS gene is very important and expressed only in the hematopoietic cells. So it is not only important for the platelet formation, but also for the immunity, all type of immunity, the T cell, the B cell, the natural killer. And that's why we see that it is not only affecting the platelet production, but also causing combined immunodeficiency. The spectrum of the disease will depend on the mutation. So we can have the very classical severe phenotype, or we can have milder phenotype where they present only with thrombocytopenia, with no immune deficiency, or the other way with neutropenia, with no thrombocytopenia. So moving on, as we mentioned, it is exclusively, so if you see a male presenting with thrombocytopenia, the very important hallmark is when you check the size of the platelets, there will be microthrombocytopenia, okay, and the mean platelet volume will be decreased, very highly suggestive of the Wiskott-Aldrich. So what is the manifestations of this? They will come early in the neonatal life with the, because of the thrombocytopenia, they will have petechiae, purpura. Look into the history, they had prolonged bleeding after circumcision. Later on, they can even history of epistaxis, gum bleeding, hematuria. The first 2 years, they are very risk of having, again, the serious complications, life-threatening complications. The eczema, which is present almost in 80% of these patients, and they will mimic atopic dermatitis. So sometimes they will be even misdiagnosed. So it is usually severe, usually it is presents with refractory type, and you will see them getting readmitted because of especially sinopulmonary infections, bacterial infections. They can even have different variants because it is combined immune deficiency. You can see viral, fungal, opportunistic. So also we should also keep in mind that if as they grow in their age, they are even prone to develop various type of autoimmune diseases. Name it, they can have the risk of it, whether it is ITP, vasculitis, arthritis, IBD, various type of autoimmune diseases. They are prone as they grow in their childhood. And also it increases the risk with age, the risk of malignancies. Around approximately 10 to 20% they have this risk. And it can be various types of malignancies, whether it is lymphomas, whether it is leukemias, myelodysplastic syndromes. So again, how you will work up the Wiskott-Aldrich when you take a CBC, again, in addition to the thrombocytopenia, we said that it is the microthrombocytopenia. Because of the recurrent infections, definitely you will do an immune workup to make sure about the T cell count. Okay, and also if you have the flow cytometry available in your services, you can use it. An immunoglobulin level, again, part of the immune deficiency. What is very classically seen in such cases is that they have low IgM with elevated IgA and IgE levels. But definitely, the gold standard way of diagnosing such cases is by doing the genetic testing. And specifically for mentioning that you have to, you're clinically suspecting the Wiskott-Aldrich syndrome. So going to briefly through the management, you will try as much as you can, bleeding prevention, symptomatic treatment, avoiding again the antiplatelet drugs because of their immune deficiency. Some of them will be kept on antibiotic prophylaxis and monitoring after vaccinations. Some of them are given regular IVIG therapy, trying to reduce the frequency of infections, and definitely for the treatment of the eczema, which is sometimes difficult. So what is it? Splenectomy has a role in Wiskott-Aldrich. It might improve the platelet counts, but it is not recommended anymore because of the risk of overwhelming sepsis. So the mainly treatment of choice is the hematopoietic stem cell transplantation, and the best outcome will be if you do it at a younger age, matching sibling donor, before the development of the autoimmune diseases and the malignancies. Otherwise, they have a good survival after the hematopoietic stem cell transplantation. And also there is a very emerging field treatment in it, Wiskott-Aldrich, where they have also in December 2025 FDA approved the gene therapy for treating it. So this is usually how they will present. They will present with bleeding tendencies, with a very severe uncontrolled eczema, and they will be requiring very recurrent hospitalization in view of the recurrent infection. Going to another syndrome, it is a very rare syndrome, but it is also good to know about it, is the Jacobson syndrome. This is because of a deletion in the terminal region of chromosome 11q. So because of this deletion, it all depends upon the genes that is present in the area of that deleted. Usually it is a de novo, means it is not inherited. Rarely it is inherited from one of the parents. Usually it is a new mutation. So depending upon the number of genes that are involved in the deletion, the severity may vary from person to person. But if the genes that are involved in the megakaryopoiosis, then it will cause what is called as the Paris thrombocytopenia. I hope I pronounced it correctly. So what is the very characteristics of this syndrome is the hematological features. Again, they will present with congenital thrombocytopenia, but here they will have the giant dysfunctional platelets. And also, not only that, they will be born with very characteristic facial features. I'll show you in the next slide. Usually, it does involve their neurodevelopmental, and it is associated with other congenital anomalies. So as you can see, again, these are photos from the internet. You can see how they have down-slanting palpebral fissure. They have hypertelorism, pointed nose. They have very small, low-set ears. small jaw. So usually they are quite dysmorphic. So keep in mind the Jacobson syndrome. So because of it is a deletion in the terminal region, keep in mind that you do a chromosomal microarray because the sequencing might not be detected. So karyotype, if it is a large deletion, then only it can detect it. Otherwise, the gold standard is the microarray testing. You have to monitor the platelet counts in such syndrome and give them platelet transfusion whenever needed and avoid the antiplatelet medication. Other syndrome, again, which will present with macro thrombocytopenia, that's giant platelets, but this time usually this is the MYH9 related syndrome. Usually if you see cases with thrombocytopenia, they have ocular, they have sensory neural deafness, they can have ocular in the form of cataract, they can have renal. These four combinations, you would think of it. It is an autosomal dominant, again, so most of the time it is a sporadic in nature. You have to think about doing for them gene study, and they will have also the other thing which will help you also in the peripheral smear is the Doherty-like inclusion in the neutrophils, which is sometimes seen in various cases and like burns, stress-related, but also seen in the MYH9 related disorders. The MECOM-associated syndrome is bone marrow failure. Usually it involves many lines, but specifically the thrombocytopenia is seen associated with such syndromes. And also they will have skeletal deformities, which I will talk to you now. So again, hematological manifestations, as I mentioned, most commonly with the MECOM-associated syndrome is the thrombocytopenia. But as they grow, it might affect other cell lines as they progress in age. It might cause from thrombocytopenia to whole pancytopenia. In addition to the hematological, they also have skeletal deformities. They will have, but sometimes you will not be detected unless you do a skeletal survey. Usually they will have some kind of limitation in their forearm. They can have thumb deformities. They can have a clinodictyly, which is the outward curvature of the little finger. What is the most also hallmark of it is the radio-ulnar synostosis, means fusion of the ulna and the radius. As you see here in the X-ray of this case, you can see the, I'm not sure if it's very clear for you, the little finger, it is outward curvature. And if you see also here in the radius and the ulna, there is synostosis, fusion. So, and if you do it, you will find that they have thrombocytopenia in their CBC. In addition, also, any with other syndromes, it can sometimes involve other organs, whether it is cardiac, renal, and also, of course, you will have to do all type of screening. Maybe also they can have also a hearing loss. So CBC, thrombocytopenia, and as we mentioned, they can progress to pancytopenia. So they can have marrow failure. They can go into a risk of developing myelodysplastic syndromes, different leukemias, and the gold standard for such cases is doing for them the molecular diagnosis. Management, supportive, whether it is bleeding measures, platelet transfusions, and if they have pancytopenia, sometimes you will have to go to GCSF or blood transfusions. But the more curative therapy is the stem cell transplant in such cases to avoid their progression into different myelodysplastic syndromes. Otherwise, if you do it, treat earlier, the better will be the prognostic factors. The congenital A megakaryocytic cytopenia, the genetics behind it is that it is an autosomal recessive disease. So what happens is that because of the MPLA mutation, it is important for binding the thrombobiotine to the MPLA receptor. So because of this, which is also as a part of it, is important for the platelet production. So what happens is that there's a defective thrombopoietin receptor. It will cause failure of the megakaryocyte development and will cause severe thrombocytopenia. And also, again, same as the previous cases, they can even move on to bone marrow failure. So neonatally, they can present early in the neonatal period with a severe thrombocytopenia with all the manifestations we mentioned earlier. They can progress again to bone marrow failure. And very characteristic is that they don't have dysmorphism. They don't have radial anomalies. They don't have, so they are usually normal at birth. They can present only initially with isolated thrombocytopenia, the congenital megakaryocytic thrombocytopenia. So how you will do it? The CBC, that is severe thrombocytopenia. Initially, the cell lines will be normal unless they progress later on and involve all the others. And by doing the thrombopoietin level, which will be very characteristically very high in such cases, because as we said, they are having problem with binding with the MPLA receptor. Again, in such cases, the gold standard way of diagnosing them is by doing a genetic testing. They can have, depending upon the mutations, they can have mild or they can have severe phenotype. The treatment is supportive. Otherwise, again, you will have to go into the hematopoietic stem cell transplant because it is the only curative treatment, because again, you don't want such cases to go into the marrow failure and also have the risk of other diseases. I will not go through this much because it was already discussed just earlier with with our dear colleague. So the TTP, just to keep in mind that it can be acquired, but definitely it also can be also genetic. So whenever you have the triad that was discussed earlier, the thrombocytopenia, the microangiopathic hemolytic anemia, neurological, all this painted manifestations, think about doing the genetics testing for them. Lastly, also, I will go through another different type of mechanism behind the thrombocytopenia is the consumptive type, where they will present with very early in the neonatal life with a vascular tumor-like, and it will be because of it is causing a markedly consumption of the platelets. They present usually with severe thrombocytopenia, so it can be very life-threatening if not catched earlier. Not only the thrombocytopenia, they can have coagulopathy, they can have very low fibrinogen level, which is also risking them into having severe bleeding manifestations. So usually the tumors, they can have different type of tumors. Most commonly is the Kaposiform hemangioendothelioma. So again, because of the trapping of the platelets, the consumption, they can have thrombocytopenia, coagulopathy, bleeding tendency. So you will see a tumor which is rapidly increasing in size, purple reddish in color, painful. They will have severe thrombocytopenia with all the manifestations, whether it is petechiae or it is mucocutaneous bleeding. And also in severe cases, they can go to DIC picture. They can have heart failure, different type of bleeding internally. So when you take labs, you will see markedly low platelets, as we mentioned, low fibrinogen. They can have coagulopathy. If there is bleeding, you have to be very closely monitoring. They can have internal bleeding, so monitor the hemoglobin. And that you might see also schistocytes in peripheral smear. Also to help you with whether you do radiological investigations, histopathology, if it is feasible in such cases, being vascular, it might be very risky. So the overall, correct the coagulopathy as much as you can, prevent the bleeding, improve the platelet counts, give supportive therapies with FFP, cryo, closely monitor the vitals. And of course, you will need a multidisciplinary team, whether they are vascular surgeons, radiology, pathology. So In such cases, also, you will need to include other type of therapies in addition to what we mentioned. You might need to add chemotherapies, mTORs, interferon, different types. And in refractory cases, even surgical embolization might be needed in such cases. So just to go, if you have congenital thrombocytopenia early in the fetus at birth or in the neonatal, early neonatal period, make sure is it persistent. Make sure one of the things which will really help also is evaluating the platelet size. We have seen how it helps us in differentiating at least some of these syndromes. Definitely, if you see more than different comorbidities, always think of genetic causes. If it is not only isolated, whether it is skeletal, whether it is different type of anomalies, cardiac, renal, always try to put them together and try to see is it fitting into a certain syndromes or not, and make sure the type of testing which you choose is correct. As you can see, sometimes it is not only choosing to do genetic, there is different types. There is microarray, there is sequencing, there is karyotype. So what is the type of test that you think your differential diagnosis will pick it up? Thank you very much.
Thank you so much, Dr. Mariam, for the excellent presentation. And I don't see questions for you, so we'll move for the next speaker. Thank you, Dr. Mariam. So our next speaker is Dr. Iman Jassim. She is a consultant hematopathologist, Salmania Medical Complex, Bahrain, a distinguished specialist with an international clinical pedigree spanning Australia and Saudi Arabia, a fellow of King Saud University and member of the American Society for Clinical Pathology. Dr. Mansour is recognized for her diagnostic precision and long-standing contribution to hematopathology at Bahrain's premier government hospital.
Thank you, Dr. Najat, and thank you for the organization committee. And we'll start to, I'll share the slides with you. Autoimmune hemolytic anemia, from that to the flow cytometry. Just an overview about the autoimmune hemolytic anemia is an acquired disorders or anemia, which is a heterogeneous group of disorders, include the warm autoimmune hemolytic anemia, the cold agglutinin disease, the mixed autoimmune hemolytic anemia, paroxysmal cold hemoglobinuria, and atypical autoimmune hemolytic anemia. The autoimmune hemolytic anemia, as we mentioned, is uncommon condition acquired in the children with the incidence of 0.2 per 1,100 per children, and it's increased with the age in the female more than male with increasing age of the children. It is characterized by development of autoantibodies. These antibodies directed against the erythrocytes antigen. As we mentioned, it's classified to 3 or more groups, the warm, cold, paroxysmal, and the mixed, and each group can be classified to the primary or secondary, idiopathic or secondary to the infection or other disorders. The autoimmune hemolytic anemia is associated with dysregulation of central and peripheral self-tolerance and the presence of the autoantibodies against the red blood cell antigen, which activate the autoreactive of T and B cell. It also includes the activation of components of the immune systems other than the autoantibodies, cytokines, complement system, phagocytes, B and T lymphocytes, including the cytotoxic CD8 T cell, CD4 T cell, regular T cell, and natural killer cells also play a role in the pathogenesis of the autoimmune hemolytic anemia. As we mentioned, the warm autoimmune hemolytic anemia can be classified to the primary idiopathic or secondary to the SLE, for example, lymphoma, CLL in adult, or secondary to the medication. The hemolysis mainly occur in the spleen, extravascular, due to the direct lysis of the red blood cells or removal of the portion of the red cell membrane. It can be fatal, severe, fatal, and in the warm autoimmune hemolytic anemia, the autoantibodies are mainly IgG. These IgG are pan-agglutinin and have limited RH specificity. Some medication, as we mentioned, it can stimulate the production of autoantibodies against RH antigen. Now, the pathogenesis, when the red blood cells are coated with IgG, part of this has the FCY, removed phagocytes in the spleen or in the liver. And the complement pathway is also activated. As mentioned here, these the red blood cells are coated with IgG and go to the spleen, removed part of it or phagocytes. These are, if it is just removed the part of the red blood cell membrane, it will be microspherocytes, which is rigid. And again, it will be removed in the liver or in the spleen. Or these coated red blood cells will activate the complement pathway, the complex C1, C2, C4, C3, C3b, and removed by the copper cell in the liver, which lead to the hemolysis of red blood cell. These are showing the microspherocytes in the peripheral blood after removing part of the red blood cell membrane, the coated red blood cell membrane, which has been removed part of it in the spleen or the liver. These are macrocytes, polychromatic cytes due to the increase of reticulocytes, which due to the hemolysis. Now, the other category of the autoimmune hemolytic anemia called CAD, cold agglutinin disease. This characterized by the temperature of the autoantibodies. It reacts below 37 degrees centigrade, but some antibodies have higher thermal amplitude. This having higher thermal amplitude cause more problem because it will cause more clinical manifestation. The antibody thermal amplitude is more important than the titer. Higher the temperature, because of the antibody thermal amplitude, the higher temperature, the closer to the normal body temperature, it will cause more of the red blood cell hemolysis. It can be due to the infection or idiopathic. A chronic hemolysis may occur extravascular phagocytes by the liver and spleen. And also intravascular hemolysis can occur also due to the complement activation. It is always IgM. IgM, IgM has the ability to agglutinate red blood cells. It can be idiopathic or secondary to the infection or lymphoproliferative disorder. The IgM antibodies mainly cause the CAD or sometimes rarely A or G, IgG or IgA. Binding of red blood cell, the same IgM molecule cause the red blood cell agglutination. Coated antibody to the red blood cell antigen antibody complex induce complement binding and activation via the classical pathway. IgM binds C1q on the membrane, activate the classical complement pathway. Now, this is the pathophysiology of the CAD. When the IgM has the ability to join or agglutinate to bind to more than one red blood cells, causing agglutination on the low temperature, and activate the complement. And then the IgM dissociates from the red blood cell and causing the complement attached to the red blood cell membrane, leading to extravascular hemolysis in the liver, or activate the rest of the complement classical pathway, leading to the intravascular hemolysis. And this is the rosette agglutinate of the red blood cell peripherally in the lab, in vitro. The other class or category is the PCH, paroxysmal cold hemoglobinuria, is a rare type of cold agglutinin disease. It is it's happened more or common in the children. Hemolysis due to the exposure of the cold. It can be even localized after drinking cold water or washing hands with the cold, because this, the antibodies activated with the low temperature, the thermal amplitude of the IgG cell at low temperature, causing intravascular hemolysis and hemoglobinuria after warming. It can occur non-specifically after viral illness, can occur after syphilis, the congenital or acquired, and it can sometimes it can develop severe anemia. This is a table showing the etiology of the autoimmune hemolytic anemia, the warm, the cold. Now, what we have to do when we are facing autoimmune hemolytic anemia or suspecting autoimmune hemolytic anemia, of course, we will start with the CBC showing low hemoglobin, peripheral blood smears showing spherocytes or microspherocytes, reticulocyte count, which is high, lactic dehydrogenase, which is high, also haptoglobin, indirect bilirubin, direct antiglobulin test. I'll go through the direct antiglobulin test and indirect antiglobulin test, bone marrow examination in some cases. Diagnostic evaluation of children with autoimmune hemolytic anemia. This is the initial evaluation, starting with CBC, as we mentioned, peripheral blood smear, and direct antiglobulin test. The direct antiglobulin test is a monospecific antiglobulin are used to detect the autoantibodies directed against immunoglobulin, particularly IgG, IG1, IG3, and the fragments of the third complement C3d, C3c, or both on the surface of red blood cell membrane. This is the blood sample from the patient, for example. The red blood cells is coated with these antibodies attached to the antigen on the red blood cell surface membrane. Adding reagent after washing the sample. The reagent contain anti-human globulin, and now we are detecting the reaction of antibody antigen. This is direct. The indirect is when we are examining the serum, because the antibodies are dissociating from the red blood cell membrane, adding the reagent with erythrocytes, coated erythrocytes, and again we are detecting the reaction of antibodies with antigen. Now, just to memorize that warm antibody autoimmune hemolytic anemia, mainly with IgG, and that will detect IgG plus or minus C3. The cold IgM, it will react at 4 degrees centigrade detection that will be complement C3 only, because the IgM will dissociate from the red blood cell membrane. Mixed cold IgM and warm IgG react at both temperature detection by that IgG and C3. Paroxysmal cold hemoglobinuria is IgG antibody class, and it will react for temperature. Detection by that is plus or minus C3. Now, there are some cases showing negative DAT. We are suspecting highly is autoimmune hemolytic anemia. And why there are chance of negative? It could be technical, 10% due to the technical effect. It will show the negative DAT. Below 5%, the possibility of negative with gel card. Gel card is more specific than the tube. This problem can be over by doing, for example, detection of the low affinity using the gel card. If we get the negative results with the tube, we can use the gel card or other method. Other methods which are more sensitive to detect the autoantibodies like microcolumn, solid phase, flow cytometry, enzyme-linked immunoradiometric method. Now, why the flow cytometry is important? Now we are getting negative DAT for so many reasons. One of them is the technical error or the low affinity of antibodies or the low threshold. Now, if we are using the flow cytometry for diagnosis of autoimmune hemolytic anemia, this can detect the small amount of autoantibodies. Can be specific for IgG, A, M, and complements C3d. Sometimes the DAT negative because there are IgA or IgG, low affinity IgG or IgA. The flow cytometry, we can get over this problem. Now, for the next few slides, I'll go through this study of Dr. Khanger. He did a study of utilization of a flow cytometry in the diagnosis of autoimmune hemolytic anemia. Is it useful? Let's see. Dr. Khanger and his group, they did a study, a prospective study with the total 50 patients. They are suspecting diagnosis of autoimmune hemolytic anemia for these patients. They did all these 50 patients by flow cytometry as well as by gel card, because we see that the tube, it may give the technical error. So they are using the gel card with it, which is more specific and showing the IgA, IgM, IgG. The age of patients ranged from 8 years to 73 years, with a median age of 44 years. There were 21 males in this study and 29 females. The inclusion criteria, they include the hemoglobin, the lactic dehydrogenase, LDH, and reticulocyte count. So at the time of a presentation, hemoglobin concentration of these varied from 5.5 to 8, reticulocyte count for these 50 patients between 5.4 to 19.1, LDH from 5 to 7 to 8 to 5. All patients, it happened that they have splenomegaly at the time of a presentation. This study was prospective, as I mentioned, over 2 years from multi-different centers. Blood sample of suspected patient of autoimmune hemolytic anemia were tested by both the gel card and the flow cytometry. Now, suspecting hemolysis in vivo include criteria, as we mentioned, for lab parameter: low hemoglobin, reticulocyte count, total serum bilirubin, lactate dehydrogenase above 500. Exclusion criteria for this study for the 50 patients was a history of recent blood transfusion within the last 1 month. Now, the flow cytometrical analysis was done by using the FACS Accento flow cytometry. The software used FACS Diva. EDTA blood sample of all patients was analyzed for detection and quantification, detection and of the red blood cell bound immunoglobulin, IgG, antibodies by flow cytometry. So qualitative and quantitation for the IgG. Patients' red blood cells were washed 3 times with a normal saline to remove unattached IgG antibodies. 1% suspicions of these washed red blood cell prepared with sheet fluid. Now, there are negative control and positive control was applied with each group of the test in a day. Negative control was considered of red blood cells from EDTA sample of normal healthy person having O positive blood group from the blood bank. The positive control consisted of red blood cells from normal healthy persons having O positive group sensitized. Now we are incubating the normal red blood cells with NTD commonly available in the blood bank. Red blood cells from the negative control sample and positive control were all washed 3 times with a normal saline, like the patient sample, exactly to remove the unattached IgG antibodies, and similarly 1% suspension of these washed red blood cells was prepared with sheet fluid. Flow cytometry. For flow cytometry, they used one stained and one unstained tube was used for each patient for each negative and positive control. Now, the quantitative results, the quantification of positive by flow cytometry is obtained by calculating the percentage of fluorescent. The calculation of percentage fluorescence is a standard technique originally described by Vander. Relative fluorescent intensity of patient, negative control and positive control was noted from the flow cytometry. So this is very important, the relative fluorescent intensity, and we will see the movement of the all event on the histogram. Qualitative and quantitative results for diagnosis of autoimmune hemolytic anemia by flow cytometry were obtained from these relative fluorescent intensity values. Now, the mean fluorescent intensity of negative control was calculated from the relative fluorescent intensity of 10 healthy group individual by taking the mean of these 10 readings, the RFI. And why we are using the RFI, why we are calculating the mean fluorescent intensity from the negative control of RFI to measure the cutoff point for the positive and negative. Now, the positive cases were defined as having RFI more than or equal to MFI of negative control plus 2 standard deviations. So the positive cut or cutoff point is the mean fluorescent intensity of negative control of the 10 healthy negative control plus 2 standard deviation, which was calculated of a negative control of the healthy individual. Cases having fluorescent more than or equal to the mean fluorescent intensity of the negative control plus 2 standard deviation were taken as a positive cases because it is more, and less having as calculated as negative cases. The RFI of 10 healthy O group individual ranges from 195 to 247 in the study. And the mean relative fluorescence intensity of 10 healthy O group individual was found to be 235. So the 235 plus 2 standard, which was calculated as 25.3. So the cutoff point of fluorescence intensity was 235, as we mentioned, 235. The RFI, the mean of the RFI for negative control was 235 plus 2 standard deviation calculated by statistical workup come as 286. So their cutoff point to define the positive and negative is above or below this mean or this number. The RFI of 10 controlled range from the positive control 1004 to 1207, which is above 286. And the 10 of and the mean of these 10 positive control, MFI of the positive control was calculated as 1051. So now we'll see the flow cytometry figures with a comparison of population movement histograms and fluorescent intensity value for the negative and positive control. We are starting with the negative control. Most of the event is moving on the Q1. Shows the population movement histogram fluorescent intensity value for one negative control in this study with the small population reactive in the Q2. There are just a few events on the Q2, but most in the Q1. So this is a negative control. This is the other histogram for the positive control. Most of the events are moving on the Q2. And see the fluorescent intensity of the positive control was 1000. The negative control was 247, which is below the mean fluorescent intensity plus 2 standard deviation. And now we'll see for the patients. This is first patient, most of the event moving on the Q2 of the histogram. And the mean fluorescent intensity of 610, which is above 235 plus 2 standard deviation. And this is a patient. This is a patient, not a control. Most of the event on the Q1 as the negative control. So their results for this study, which was prospective over 2 years, with 50 patients suspected cases of autoimmune hemolytic anemia were tested by the flow cytometry and the gel card method for detection of red blood cell bound IgG. Out of these 50 cases, 41 cases turned to be positive by having fluorescent intensity above 286, and 9 were negative, having fluorescent intensity below 286 by the flow cytometry. So now, we just compare the results with the gel card and the flow cytometry. Out of the 50 cases, 34 cases were positive by the gel card, by the Coombs test, or the direct antiglobulin antibodies, positive, 34 cases. And by flow cytometry, both are positive, showing the mean fluorescent intensity of 664. 7 cases were negative by the gel card, by that, and were positive by the flow cytometry. And the mean fluorescent intensity, the range between 482 and 547, which means that the gel card cannot detect the antibodies below below some specific threshold, which can the flow cytometry detected. Now, 9 cases were negative, even suspecting hemolysis by all the parameters in the lab, but it's still negative by the gel card and the flow cytometry. And the mean fluorescent intensity was 252. In conclusion of their study, they say that the flow cytometry is a reliable, sensitive method for detection of cell-bound IgG antibodies for the diagnosis of autoimmune hemolytic anemia. This can be used for those suspecting autoimmune hemolytic anemia cases where the gel card test is negative. So they are advising to use the flow cytometry when we are suspecting autoimmune hemolytic anemia with a negative DAT. In conclusion, after reviewing the autoimmune hemolytic anemia, the classification, the subclassification, the causes, the etiology, the epidemiology, still the DAT, direct antiglobulin test, remains the cornerstone of diagnosis of autoimmune hemolytic anemia. But negative DAT does not exclude the disease. What to do? Flow cytometry offers higher sensitivity for detection of low level of red blood cell bound to immunoglobulin and complement compared to that. Flow cytometry, it can be worked or incorporated in the future for diagnostic workup to improve diagnosis accuracy. But taking home message is still the DAT is the cornerstone for diagnosis of autoimmune hemolytic. These are some of the studies which we went through during the last 20 minutes. And by this, I would like to thank you.
Thank you so much, Dr. Iman, for the excellent presentation. As we don't have questions, we'll move to the next speaker. Our next speaker is Dr. Hind Bafagih. She's head of Pediatric Intensive Care, Prince Sultan Military Medical City, Riyadh, Vice President and Secretary General, Saudi Critical Care Society. Dr. Hind Bafagih is a leading figure in Saudi Arabian critical care medicine as the head of Pediatric Intensive Care at the Prince Sultan Military Medical City. She directs the clinical and strategic operations of a premier critical care facility. Her leadership extends to national level, where she serves as the Vice President and Secretary General of Saudi Critical Care Society and chairs the Scientific Committee for the Pediatric Critical Care under the Saudi Commission for Health Specialties. Through these roles, she is instrumental in defining clinical standards and advancing the professional landscape of critical care across the Saudi Arabia. Welcome, Dr. Hind. Dr. Hind? Hind, there is no voice. Maybe you need to unmute yourself. Hind.
معليش سوري السلام عليكم
عليكم السلام.
معليش السلايد واضحة طالعة
Yes, نعم.
أيوة. السلام عليكم everybody sorry شكرا على المقدمة الرائعة من حضرتك. I wish and I thank you also and thank the scientific committee for giving me the opportunity for such interested subject in pediatric intensive care, which is the bleeding in child. I tried to do a thorough review for the latest update, as everybody, especially in critical care, aware such a unified bleeding for definition in pediatric critical care not yet finalized or validated, but the latest two major consensus. I will try through this lecture to define it and discuss it with everybody, hoping it will be interested for the audience. So my objective in this presentation to talk about bleeding definitions, classifications, clinical assessment, management approach for critically ill child with special consideration in bleeding, and the point of care ROTEM. I will have 2 or 3 slides to talk about and how much it's important in presence in the ICU. So bleeding is the loss of a blood from vascular system into external tissues, body cavities, organs, or external environment as a result of trauma, surgery, vascular injury, or thrombocytopenia, coagulation disorders, or systemic disease. It can be as a major bleeding or massive bleeding. If it is major bleeding, it is a clinically significant bleeding associated with one or more of the following: whether hemodynamic instability attributed directly to bleeding, or a decrease in hemoglobin level more than 2 grams per deciliter within 24 hours attributing directly also to bleeding, or requirement for transfusion, backed RBC transfusion due to bleeding more than about 20 mils per kilo estimated. New or worsening organ dysfunction attributed to bleeding, requirement for surgical, endoscopic, radiological, or invasive intervention to control bleeding, bleeding that can occur within critical organ or anatomical site, such as intracranial, intraspinal, intraocular, pericardial, pulmonary, with respiratory direct compromise. If it is massive, it will be leading to hemorrhagic shock or anticipated transfusion more than 40 mils per kilo blood product, or replacement of more than 50% of the total blood volume within 4 hours from presentation, or replacement of 1 blood volume within 24 hours. So, as I mentioned, there is a consensus done through PEDIATRIC group that was in 2019, and there was an elite of different physicians, pediatric intensivists, pediatric cardiac intensivists, pediatric hematology, oncology, transfusion medicine specialists, pediatric surgeons, and pediatric anesthesiologists, and they are from North America, Europe, and Australia. And they define the clinically relevant bleeding according to severity, which we reflect the severity and clinical significance of the bleeding based on impacts on organ function, hemodynamic stability, hemoglobin loss, and measurable blood loss in critically ill child. This definition being reviewed in 2021 in a good systematic review article by the same group, and so far no more we can objective definition that help in the ICU more defining the severity of clinically relevant bleeding like this definition. The basic definition for clinically relevant bleeding is the first physician-driven diagnostic criteria for bleeding derived by expert consensus, as I mentioned, applicable to critically ill child, which is validated consensus definition for critically ill pediatric admitted to PICU. Bleeding severity have been classified according to the bleeding assessment scale in critical ill child, and this is what the next slide will explain. Additional procedures, specific bleeding definitions not included but considered. such as the bleeding from patient on ECMO, cardiac surgery, post-neurosurgery, may be applied and as clinically appropriate. This definition based on the severity. If you can see, any of the following criteria define severe bleeding, where they said the bleeding that lead to at least one organ dysfunction according to pediatric score criteria for organ dysfunction within 24 hours of the previous assessment. If there is no assessment, you assume it normal. And that organ dysfunction should be associated directly to bleeding. Or a bleed that lead to hemodynamic instability because of increment in the heart rate more than 20% from the baseline, or reduction in the blood pressure more than 20% from the baseline, directly related to bleeding, leading to hemodynamic instability. Also, if that bleeding have drop of hemoglobin more than 20% within 24 hours, the drop of that hemoglobin should be associated also directly related to that bleeding in the absence of other causes. Quantifiable bleeding more than 5 mL per kilo per hour for more than 1 hour through any drain or chest tube. Direct intraspinal bleeding leading to loss of neurological function below that lesion. Non-traumatic intra-articular bleeding leading to decreased range of movement, or intraocular bleeding leading to impaired vision. So you can see all it is bedside clinical diagnosis, non complicated or complex, is very easy, helping for acute management and immediate action to solve the severity. If it is moderate bleeding, the bleeding should be more than minimal bleeding, which I will discuss here, but without any criteria of the above. Bleeding that not leading to organ dysfunction. Bleeding is not leading to hemodynamic instability, although it could have a change in the heart rate more than 20%, but the drop of the blood pressure less than 20%, not more than 20%. Quantifiable bleeding between 1 ml per kilo per hour to 5 ml per kilo per hour. Where is it? Yes, through drains or chest tube. Any of the following can lead to minimal. So we have severe, moderate, and now minimal. Minimal: streaks of blood in the ET tube or during suction only, streaks of blood in nasogastric tube, macroscopic hematuria less than 1, plus RBCs present in dipstick, subcutaneous bleeding less than 5 centimeters in diameter, quantifiable bleeding less than 1 ml per kilo per hour through chest tube drain, much less than in severe and moderate. Bloody dressing required a change to be changed no less than 6 hours, or weighing more than 1 ml per kilo per hour due to slow saturation. Progressive: if mild to moderate or moderate to severe being rapidly changed, this is severe, incorporating with clear hemodynamic instability, progressing to organ failure. Fatal: any bleeding that directly can cause or lead to death will be characterized as fatal bleeding. And this is the best definition, which helped the intensivists to manage according to the severity and the equity of the case with rapid intervention. As I mentioned, the classification of bleeding within critical care also, or out of the scope of critical care, being handled in this basic study or consensus, apart from the severity according to the location, anatomical site, location, whether it is external or internal bleed, external such as epistaxis, gingival bleeding, vein puncture, and so on, internal intracranial hemorrhage, pulmonary hemorrhage, or any organ involved. Anatomical site, as you can see from the table, it can be involving any organ, and this is what we call anatomical and location classification. According to the hemostatic defect, also they classified into primary and secondary hemostasis bleeding and mixed hemostatic defect, which is well known for everybody. If it is a primary, the defect should be in platelet or numbers or function or vascular integrity disruption. If it is secondary, it could be deficiency or dysfunction of coagulation factor resulting in impaired fibrin clot formation. Mixed, it is in between combined abnormality, both primary and secondary. And you can see the clinical feature here, and the most common examples related to primary or secondary or mixed hemostatic. طبعا from ICU point of view, a mixed hemostatic defect, this is the most common that we can see, especially in septic patient DIC or severe liver failure, massive transfusion associated coagulopathy, ECMO patients associated coagulopathy, and severe sepsis induced coagulopathy. عفوا. And here it is a symbol comparing between secondary and primary hemostasis, where defect, petechiae, purpura, epistaxis, gingival bleeding, very common in primary, rare and uncommon in secondary. Hemarthrosis, intramuscular hematoma, delayed bleeding after surgery, and deep organ bleeding. It is rare here to uncommon in primary and very common in secondary hemostasis, which is very important for us as intensivists to be aware about that. Okay, now the classification according to pathophysiology categorization, whether it is consumptive coagulopathy, hyperfibrinolytic bleeding, dilutional coagulopathy, or combined coagulopathy. If it is consumptive, this is excessive activation and consumption of a platelet and coagulation factor resulting in depletions of hemostatic reserve. And mostly we can see diffuse bleeding from multiple sides and so on, seen in DIC, severe septic patients, trauma, malignancy, severe tissue injury, and of course, extracorporeal patients, ECMO patients. If it is hyperfibrinolytic bleeding, it's according to that, to this classification, excessive fibrinolysis leading to accelerated breakdown of the fibrin clot. And here we can see the patient will have persistent oozing, delayed rebleeding after hemostasis, excessive post-operative bleeding, diffuse mucosal bleeding. And this is, we can see it post-operatively sometimes. This is or post-trauma. So common cause, major trauma, liver failure, cardiac surgery, ECMO patient, thrombolytic patient on thrombolytic therapies, and acute promyelocytic leukemias. Dilutional coagulopathy, dilution of the platelet and coagulation factor due to large volume resuscitation, whether of fluid or blood product administration. And this will lead to generalized bleeding, metabolic acidosis, prolonged clotting time, increased transfusion requirement, and mostly massive transfusion problem or large volume crystalloid resuscitation, as I mentioned, ECMO priming, post-ECMO priming, major surgery, severe hemorrhagic shock. If it is combined coagulopathy, simultaneous consumption, hyperfibrinolytic and dilutional mechanism. And here, severe multi-site bleeding with progressive coagulopathy and hemodynamic instability. And also seen in massive hemorrhage, trauma, ECMO-associated bleeding, liver failure, and septic shock. And you can see that most of the dilutional and combined coagulopathy seen in ECMO and septic shock patients severe septic shock, and those patients on receiving massive transfusion, which is a very bad scenario for any intensivist to deal with, but it is manageable. This is a simple table showing you the difference between the consumptive hyperfibrinolytic bleeding and dilutional coagulopathy from platelet count, BT, BTT, and fibrinogen D dimer, and they're very aware. All the physicians should be aware about it. Clinical scenarios that we can have in pediatric intensive care that predominate leading to bleeding, septic shock with DIC. And this is consumptive coagulopathy. Severe meningococcemia, also consumptive coagulopathy. Major trauma, hyperfibrinolytic plus or minus consumptive coagulopathy. Massive transfusion protocol activation can lead to, if it is not properly being transfused with the rules of 111, can lead to dilutional coagulopathy. Post-cardiac surgery bleeding, you can see the hyperfibrinolytic plus dilutional. ECMO bleeding, mixed consumptive, hyperfibrinolytic, and dilution. Acute liver failure, hyperfibrinolytic, and coagulation factor deficiencies. Massive GI hemorrhage with transfusion, dilutional coagulopathy. This is a very nice summarized. Always we are advising our fellows to memorize, to help them directly and manage. Now, the classification of bleeding according to different aspects, whether medical, surgical, trauma. This is a very nice summarized different cases in the ICU, from oncology, from cardiac surgery, ECMO-related critical illness, which I will pass over it. Now, before I will go to the approach, I will have 3 slides talking about bedside bleeding assessment in PICO. This is a very nice reminder for any intensivist bedside to ask if he had encountered a bleeder, a child with a bleeding. So 4 Ys, 4 W, 1 H, and 3 Is. لو جينا نقول 4 Ws, where is the bleeding? This is the very question that we should ask ourselves about. Where is the bleeding? Is it external or internal? And the cause, directly trauma surgery, according to the clinical examination and the presentation. What anatomical site is involved? This is second question. Is it any organ? Site-specific disorder. And we will do immediately CBC coagulation imaging according to the need. Third question, what is the bleeding hemostatic defect? Is it primary hemostasis, secondary, or mixed? And as I mentioned previous slides, DIC, factor deficiencies, platelet disorder, and also you will do the test accordingly. What is the underlying pathophysiology mechanism? Is it consumptive, fibrinolytic, dilutional, mixed coagulopathy, and which common cause for that? Sepsis, ECMO-related, massive transfusion, and trauma. H, how severe is the bleeding? And this is minimal, moderate, severe, progressive, which is very important for any intensivist to act quickly and to replace the bleeding according to basic assessment tools. As I mentioned, 3 Is. Is the patient stable? Is the bleeding localized or diffuse? Is the bleeding controlled? And this is the 3 questions, very important. If it is stable or unstable, it makes difference. Is it life-threatening or not? Because the action will be quickly, and if he's unstable, it could be ongoing hemorrhage leading to shock, further massive you will go in the circle of massive blood transfusion, and then you will be in a vicious circle where end with metabolic acidosis, DIC, and instability. Is the bleeding localized or diffuse? The same. Surgical, if it is localized and identified, surgical source clear. Here, it can be interfered surgically or through IR. Is it controlled or ongoing? It means that you will use the full support in the ICU, including the ABC that I will mention later, including inotropes, full transfusion, all factors, factor 7, vitamin K, cryoprecipitate, fresh frozen plasma, blood product, to control that source. If it is surgical, you need, whatever you will do, need to do surgical intervention, but you need to stabilize the patient to be able to go to OR. So practical bedside bleeding assessment also, we said medical, surgical, trauma, procedure, whatever, is that due to an underlying disease, is to know what you are dealing with, especially in critical illness, the DIC, sepsis, multiple organ dysfunction. This is a very encountered problem in the ICU, and it is a nightmare for us, but we are trying to interfere and to support the patient before we will go to that level. So the time that you will do the bedside assessment, you need to consider A, B, C, D, E, H. The airway, breathing, and circulation support to overcome the shock, to overcome the bleeding if there is, and to control the airway by intubation, and using high technique of high PEEP to control the bleeding if it is pulmonary hemorrhage, and of course to secure the airway by intubation, hoping not to proceed in critical airway because of the bleeding. Disabilities, it depends on the organ involved, especially the neurological one, any external bleeding, and using all the tools bedside to have rapid, quick reading through CBC, coagulation study, fibrinogen, D-dimer, and ROTEM, which is involved I will talk about it in most of the ICUs for rapid goal-directed replacement for coagulopathy identification. So now we will come to how to approach. You need to know there is an early sign, progressive signs, and severe signs. The early sign, tachycardia, pallor, delayed capillary refill, and mild lactate elevation. This is very important, and you need to consider. I'm talking now about pure patient with the bleed, not septic, nothing, just a bleed. Progressive signs can later, a few hours, the patient hypotensive, decreased urine output, altered mental status, and metabolic acidosis. To reach this level in pediatric, it is difficult because the early sign detectable much easier. The pediatric, unless there is a continuous hemorrhagic shock, it can identify within minutes to hour about the hypotension. Otherwise, if it is a slow bleeder, it will be late. Severe signs, hemorrhagic shock, multiple organ failure, and cardiac arrest. And this is the first detection. Bleeding should be suspected in any patient coming to ICU, active blood loss, unexplained anemia, sudden hemodynamic deterioration, persistent oozing from invasive sites, and unexpected postoperative instability. It could be medical or surgical conditions. If it is medical condition, the red flag usually renal failure and hemodialysis, GI gastrointestinal bleeding, sepsis and DIC, idiopathic pulmonary hemorrhage, and central nervous system bleeding. This is all red flag for us. If it is surgical condition, any patient can with spinal surgery, cardiac surgery, or on ECMO. Need to be careful and not to miss bleeding in those type of patients. As I mentioned, for life-saving assessment in pediatric, airway, breathing, circulation, disability, exposure, and factor fibrinogen hemostasis. So for here, you need to secure airway and breathing by intubation and controlling the bleed, increasing the beep. You could install factor 7 directly or tranexamic acid through ET tube if there is pulmonary hemorrhage, just to control, plus the other supportive blood product that we can give. Circulation, control the hemodynamic by avoiding hypotension as much as we can through direct fluid resuscitation, blood product resuscitation, and use the inotrope when if it need. Especially if it is neurogenic shock, use norepinephrine. Disabilities and source control, it depends on from your thorough examination if there is any clear source, surgical I mean, or it need intervention to be clarified and discuss it with the physician related to control as soon as possible. Exposure, this is for skin. The most important thing to keep patient warm. And we will see why, because one of the red flag and bad I can see diamond of death is the hypothermia, which we need to avoid because it worsens the coagulopathy picture. Look for the factors, fibrinogen and hemostasis, and that's why we need Rotem, a bedside test tool that help us in rapid detection and management. After that, you detected everything. The most important blood work that we need to do as soon as possible, CBC, coagulation, profile, fibrinogen, D-dimer, blood gas, lactate, ionized calcium, liver function, renal function, cross-match and blood group, and Rotem if we have. So if you diagnosed that bleed, your management should be goal or targeted therapy. That's to say, packed RBC, you need indication, clear indication for hemorrhagic shock, ongoing severe bleeding, or symptomatic anemia. The amount 10 to 15. Our goal always for critically ill child to keep his hemoglobin 8. Sometimes if it is cardiac related or other it can be 10 gram per deciliter. Hemoglobin more than 10 gram, usually our goal if we have active continuous bleed. Second, fresh frozen plasma to keep INR indication if it is INR more than 1.5, if BTT prolonged, massive transfusion, or clinically indicate disorder, hematological, oncological, or DIC. Those 10 to 15, our target is to keep the INR less than 1.5. Platelet, our target, it depends on the kind of bleeding and situation, clinical situation that we need to keep in. If we have active bleeding, we will need to keep the, regardless of the cause, the platelet more than 50,000. In neurosurgery cases or CNS bleeding, we need to keep the platelet more than 100,000. In massive hemorrhage, keep the hemoglobin, the platelet 75 to 100. Cryoprecipitate needed if we have low fibrinogen. Fibrinogen concentrate according to the local protocol that we use per center. Our goal to keep fibrinogen between 150 to 200. If there is a CNS bleed, we want it more than 200 milligram per deciliter. Tranexamic acid, special indications, 15 we can give loading of 15 milligram per kilo IV over 10 to 15 minutes and maintenance 2 milligram per kilo per hour infusions as needed. Mainly in trauma bleeding, surgical bleeding, pulmonary hemorrhage, selected cases, and major hemorrhage with hyperfibrinolysis. So, during the hemostatic resuscitation, we need to correct lethal triad and to avoid having them. So what we call correct the diamond of death, which is hypothermia, acidosis, hypocalcemia. So hypothermia, avoid hypothermia and keep your patient, his temperature at least 36 and above. Acidosis, correct the shock, improve the perfusion, and improve the, correct the pH. Hypocalcemia, keep your ionized calcium more than 1.1. Coagulopathy, correct it according to your bedside rotem if you have, or the lab. But the most important thing is to correct the lethal triad: hypothermia, acidosis, hypocalcemia. The combination of hypothermia, acidosis, coagulopathy, and significantly worsen the bleeding and increase risk of mortality of critically ill child. Is there a special consideration? Yes, there is a special consideration. If we have specific medical therapy cause, you need to be aware, and this is from the first detection that you will have warfarin, drug-induced like warfarin, heparin, disease-related DIC, liver failure, thrombocytopenia, hyperfibrinolysis, hemophilia, von Willebrand. It depends, and you will treat accordingly. Source control, if you have fallen in massive transfusion, you need to follow the strategy. 20% blood loss in less than 1 hour. This will be a massive bleeding, and you will go in a massive transfusion protocol. 50% of blood volume loss less than 3 hours. See the very acute loss of blood. Infant blood volume ممكن تكون 90 ml per kilo, older 80 ml per kilo. This is what we are talking about, blood volume loss in less than 3 hours. So how to treat that? By the balanced transfusion equation plan, 1 to 1 to 1. Packed RBC 1, fresh frozen plasma 1, platelet 1. This is commonly recommended in pediatric major hemorrhagic protocol. So just be careful on that 0 time of presentation, how many hours he presented and waited, and how much he lost, at least even by estimation. Surgical and interventional hemostasis depending on the bleeding source. For any source to control, early consultation should be obtained according to the bleeding site. Pediatric surgery, cardiothoracic surgery, neurosurgery, ENT, gastroenterology, interventional radiology. If there is surgical hemostasis that we want to end with controlling, look for uncontrolled post-operative bleeding, direct contact to the surgeon, intra-abdominal hemorrhage, thoracic hemorrhage, vascular injury, traumatic bleeding, anastomotic bleeding. And of course, they will go for re-exploration, physical ligation, surgical backing, damage control surgery. It depends on the surgeon and the case that been involved. For interventional, if there is a vascular injury, endovascular intervention we need, pelvic bleeding, hepatic bleeding, splenic, renal, vascular malformation, GI bleed. So the procedure, angioembolization, endovascular stenting, or coil embolization. This is according to the case, acute, and especially for acute ischemic limb, which is an emergency intervention. Other sources can be involved in endoscopy, ECMO circuit assessment, and hold, and sepsis source control by controlling the infection, treating by antimicrobial. Reassess is very important in the critically ill child with bleeding every 30 to 60 minutes. And our assessment will go with bleeding, BICO bleeding bundles, looking for airway and oxygenation, B for blood product and balanced resuscitation, control the source of bleeding, D for correct the diamond of death, which is, we said, prevent hypothermia and prevent correct acidosis, correct calcium, and of course the coagulopathy. E for evaluate with Rotem and frequently, and F for fibrinogen and other factors replacement according to the need. You need to keep always in the continuous monitoring target hemoglobin more than 8 to 10 gram, platelet more than 50,000, and CNS speed more than 100,000, fibrinogen. You need in massive hemorrhage 200 milligram per deciliter, INR less than 1.5, and pH keep it more than 7.25, lactate more than less than 2, temperature more than 36, and ionized calcium more than 1.1. As this is a very important, I said, peers in hemostatic resuscitation in pediatric intensive care, which is use of rotational thromboelastometry. It is a point of care physicoelastic coagulation test that provide a dynamic real-time assessment of the entire coagulation process in whole blood. It's widely used in intensive care units, cardiac surgery, trauma, liver transplantation center, and major bleeding management to guide agreed targeted and evidence-based transfusion therapy. Rotem will evaluate the initiation, formation, strength, and breakdown of the clot, allowing the clinician to rapidly identify specific coagulation problem, abnormalities, and administers most appropriate blood product or hemostatic therapy. عشان كده it is very nice tool in any ICU. Rotem facilitates goal-directed hemostatic management, as I mentioned, identify the underlying cause of the bleeding, optimize the use of blood product, reduce unnecessary transfusion, and improve the patient outcome in severe hemorrhage massive transfusion scenarios. It could be extem, looking for extrinsic pathway, intem, intrinsic pathway, fiptem, fibrinogen function, aptem, hyperfibrinolysis, and heptem for heparin effect. You can see the Rotem finding if it is CT prolonged coagulation factor deficiency, like use the concentrated the fresh frozen plasma. Fiptem, if it is less than 7 millimeter fibrinogen deficiency, cryoprecipitate and fibrinogen. Extem, platelet deficiency, extem ML more than 15%, hyperfibrinolysis, tranexamic acid, intem, prolonged but heptem normalized, heparin effect, multiple abnormalities, mixed coagulopathy, and massive hemorrhage, and here active massive transfusion and protocol. And usually if you have it, we are in our unit, we are putting a table with each finding for quick intervention. This is again the same.
Dr. Hind, please, you exceeded your time. Can you please summarize?
Okay. خلاص أصلا آخر حاجة. This is stop the bleed. It's a simple control and take home message. Treat the patient, not the laboratory failure. Early recognition save lives. Control the source of bleeding immediately. Resuscitate and stop bleeding simultaneously by airway stabilization, circulatory support, blood product replacement, and source control must occur in parallel. Use goal-directed transfusion whenever possible and avoid the diamond of death. Transfuse the right product for the right defect. Monitor response continuously by reassessment and the vital sign laboratory findings. شكرا.
Thank you so much, Dr. Ahmed, for the excellent presentation. And as we don't have questions for you, we'll move to the next speaker. Our next speaker is Dr. Munir Al-Bukshi, consultant pediatric hematologist oncologist, Al-Mana General Hospital, director multidisciplinary team for bleeding disorders, Saudi Ministry of Health, a key architect of national hereditary blood disease programs in Saudi Arabia, formerly director of the Hereditary Blood Disease Center in Al-Hsa. Dr. Al-Bukshi continues to share national standards of care through his leadership in multidisciplinary teams and medical education. تفضل دكتور منير.
بسم الله الرحمن الرحيم. Thank you, Dr. Najah, for the invitation and for the excellent introduction. Let me just... Yes. Today I will speak about something which is different from what the previous speakers, including yesterday and the day before. You know, in medicine, we are searching all the time for something which is... did you hear my voice?
Yes, Munir, we can see your slides and we can hear you. Please.
Okay. For medical progress, all the pharmaceutical companies, researchers, the multidisciplinary scientists, they are searching for something to improve the quality of life of all the human being. And as you know that previously we have seen that we have antibiotics starting from penicillin, from rotted bread, something from even from the sewage part and the drains. Antibiotics like vinblastine, vincristine, and so on, anthracyclines, chemotherapeutic agents, they were discovered from a natural product. Today I will speak about henna, which is a product which is used in tradition of thousands of years, which is well-known plant in old Egypt, North Africa, and it was also in the Babylonia time, that means we are talking about something which is 4,000 years before Christ. So which is well documented in the natural history museums and also in the old medical textbooks. So in Egypt, I summarized it was even being used for the mummies and for their preservation for the afterlife. And at the same time, it was being, you can see that Ramses II mummies, his eyes and the nails were painted after his death. And the queens, they were being painted there. And it is another role for it, which is spiritual protection and for preservation and cosmetic reasons. Again, they were using it in medicine other than preserving mummies for life. There was for skin remedy like skin infections and for preserving hair and and of course for cosmetic body arts and tattoos and for beauty. And there are myths about the queen and the king, Isis and Osiris, that the henna will make symbol of loyalty and love between holy spirits. Now let us talk about henna. Henna, we have 3 types of henna, which is these are the common types. The first one, you can see there are 3 plates, and all of them they have similar green, which is dried things. The first one, which is called natural henna, which is a plant from Cassia obovata. And the middle one is the red henna, which is the commonest. This is Luciana intrimus, and black henna, which is mixed between natural and artificial chemical substance. First, let us speak briefly about Sina italica, which is the neutral henna. You can see the plant. This is very common. This is from even my house. You can see this oval shape leaves, which they are green all the times, and with this pale yellow flowers. The flower and at the same time the dry leaves, they are very important. If they are, you can see that no animal will go to to this plant, and they will not eat it because they knew that it can cause problems for them. For the phytochemical analysis of the plant, they have discovered that it has anthraquinones, which is especially the sulfuric acid, which is remarkable antifungal, antimicrobial, antibacterial activity. And at the same time, it is being used for hair to strengthen the thin hair traditionally, and now being implemented in several creams and products for cosmetic and others. In medicine, you can see this purgative laxative, which is produced by pharmaceutical company. This is the Sina glycoside, which is a well-known purgative. Initially, it was by traditional medicine, and now being produced and manufactured pharmaceutically. There was as we mentioned, that there is antimicrobial and antifungal activity, which is implemented or proved by the extract, which is should to be very effective in the ringworms and for bacterial pathogens, especially methicillin resistant Staph aureus, which is important. This is why now being manufactured in the local therapies for MRSA. Traditionally, which is not proven but used for fever, for diarrhea even in low doses, and for some venereal diseases initially. Because of the extract have excellent antioxidant agent and anti-inflammatory, the extract showed good absorption by the skin and improve skin care, skin healing. And for the hair, as mentioned, for cosmetic and to strengthen the hair ties. Now let us speak about our common henna, which is the red henna, which is being used in most of the Middle East, North African societies. This plant, which is green all the year, and you can see these are the green leaves, and these are the ones which contain active substances also. So the name is different from different cultures. It is originated from North Africa and Middle East, then spread to India. Then from India, it was migrated for use all through the world, and for many reasons, especially for cosmetic reasons. And here you can see also the pale yellow flower of beetles. The phytochemical analysis of Rosania, they have discovered several activities in this plant. One of them is the antioxidant activity, which is very strong in the red henna extract before extracting the exact molecule which is having more of oxidant. So in rats, what they have done, they have infected wound for them, and it showed that they improve the wound healing for them without adverse events. And the reason for that, they mentioned that there are more phenolics observed in this condition. Another benefits in medicine is anti-inflammatory and analgesic activity. It was found that with the use of henna extract, it showed that it is inhibiting COX-2, prostaglandin, reducing tumor necrosis factor, interleukins also. So and it is more potent than aspirin in experimental model, and hopefully there will be a phase 1 trial for for phase 2 trial for this condition instead of from labs to human being, and to produce another product. And there is overall evidence that henna or Luciana, which is the tree extract, is having direct effect on pain and on anti-inflammatory conditions. There is another effect on hair. You can see by electron microscopy. This is the control thin hair. What happened after application of henna extract, after oxidation of this henna? Because henna activity should be, it is not with the dry product or dry leaf, but because they need to be activated. And activation, I will show you later on. See what happened, and the hair. See how is it? This wrinkles, the wrinkles, they improve, and what happened that the roots and the hair itself became more strong with time of application. But there is adverse event which with frequent dyeing the hair, what will happen that the natural melanin production in the hair follicle will be reduced with time. Another medical benefits is anti-parasitic activity. Luciana or the red henna is ethanolic and have methylonic extracts was assessed, which showed that it is have direct anti-parasitic. Beside, it is augment the anti-helminthic activity of anti-helminthic drugs. So in the future, it is a potential for combination of anti-parasitic, anti-helminthic with henna extract. Again, there is gastroprotective activity which was found in ICUs for patients who developed decubitus ulcers, and this claim need to be reproduced by other studies, that the time for the ulcer healing is shorter when they are painting these ulcers with henna. Wound and burn healing activity, another benefits that have been seen when it was evaluated. Those infected wounds in rats, they have seen that there is improvement in 71% in those used henna extract, whereas 58% in the control group. And severe burns have been treated with herbal ointment with fermendol, which is also from red henna extract. They showed marked improvement in these patients. Another activity which is being stabilizing the glycemic activity in Luciana inermis, red henna, which reduces blood sugar and cholesterol.
Dr. Munir.
I think Dr. Munir has a technical issue.
Hello? Hello?
نسمعك دكتور منير.
Can you hear me?
Yes, doctor. We can share the slide from our end, and we give you the control.
Can you see slides or you cannot?
I can share the slide from our
Yes, yes,
end.
we can, Dr. Munir, continue. Yes, please continue.
Okay. So now how to activate the Lawson from Lithuania. This is by either by mixing it with water as traditionally or adding some sort of weak acid. So it will slow the hydrolysis and make good oxidation with time. And this is to make the Lawson active material. And when they studied this and they extracted, it was shown that Lawson is the main chemical compound in the red henna. Can you move the slide? Because I cannot move the slide now. Okay. So the chemical composition of red henna, because it has several quinones, phenylpropanol, phenoloid, triploid. Then they have the main thing is the quinones, which are having more of pharmaceutical applications. They extracted at least 12 chemical compounds, mainly the Lawson. The Lawson is the main one that I will talk about now. And before that, you can divide all these 12 into either phenyl proponoid and phenoloids. And these are the bioactive materials after the henna extract being oxidized. The Lawson now, it is the coloring agent which make henna instead of green into a red color, either in hair or in tattoos and hands and fingernails. This material is very the active one. It shows that it is having 2-hydroxy naphthoquinol, which is almost similar to naphthalene compound. You can see the chemical one, and it has 3 isomers, and they are active. They are active compounds, and they have how they extracted after drying. They have centrifuge and spectrometry. Then they have done studies. Then they have studied this the Lawson and rats. What are the biological activities? You can see it is anti-tumor activity, anti-inflammatory, antibacterial, antioxidant, mitochondrial dysfunction, antifungal, cytotoxic activity, and anti-sickling agents, which was of interest in this. You know, in sickle cell disease, what happened with this mutant hemoglobin S? It is very generous. It is quickly shifting the oxygen dissociation curve to the right. So it is depriving the RBCs from oxygen, making these things, instead of the biconcave, it will make these strands, which is the primary molecule, which will cause the sickling process. What happened after incubating Lawson compound in the red cells of these? You can see this very sickling blood film. After 30 minutes, this is what happened. It shifted the oxygen dissociation curve to the left side. That means the oxygen delivery will be slow in these red cells, so it is delaying the sickling process in sickle cell disease red cells, which is, again, it is a potential for a pharmaceutical therapeutic agent to prevent sickle cell crisis. Another thing, other materials that contained in Lawsonia, other than Lawson, you can see these compounds that I will touch them with each one slide. Anti-leukemic or anti-leukemic and cancer research showed that the Lawson it has stopped the mitotic figures in cancer cells, which is very, very important, and stopped the cell division. And now there is phase 1 study to see how the Lawson being used in oncology. Another molecule which is a beginning, again, it is anti-cancer. It is induced apoptosis in cancer cells, also causing cell cycle arrest with inhibition of metastasis and targeting cancer stem cell, which is very important, and interfere with signaling pathways in these signaling agents. So this is the summary of beginning, and you can see how important this molecule in the future in oncology. Again, there is another one, which is letulinol, which is a promising natural painkiller. And you know how pain will be induced from the start until signaling agent. It is modulation, projection, and the pain perceptions in the central nervous system. And this is again another frontier in pain management, especially in chronic pain, not only acute. It is more of acute pain conditions like rheumatoid and cancer patients. Fourth molecule is labacol, which is interfere again with cell cycle and inhibit proliferation and migration of several cancers. The famous one is the bladder tumors cells, which affect the RNA. And there are a good number of studies that proven that it is they use it as secondary to prevent metastasis. And acute myeloid leukemia, hopefully there will be a new clinical trial which will involve this patient. Another cancer, which is in lymphoma, prostate cancer, and non-small cell lung cancer, but this is only in animals so far. Fluoxetine, another anti-tumor agent, which showed that exhibit prevention of metastasis. So it is for secondaries mainly, and again improve the immunity on patients with sickle cell, for those with metastatic cancers and chronic pain. Gallic acid, this is a nice molecule which is having a very potent antioxidant which neutralize free radicals from cells and reduces the inflammation, and it is being used currently to improve skin color. So those who needs to lighten their skin, they can use it. Antimicrobial agent for fungi and even viruses. And it is anti-inflammatory agent but it is not used as anti-inflammatory currently in medical formulation. Quercetin, this is another molecule which is mainly in working on blood pressure as controller, but again it has another effects in managing allergy, stabilizing these cells, prevent lipid accumulation, and avoid hypertrophies of abnormal cells. The antimicrobial activity that being seen in most of those Luciana products, most of those molecules, it has excellent, you can see profile for bacteria, candida, and other ringworms. So it is being produced or it will be produced recently in the future. All this has this Luciana or red henna. It is very safe compound, but it has several side effects. Erythema because of the contact with skin lesions, pruritus. If it is taking oral, it will change the mood if it is taking oral, and they have seen that the risk of suicide will increase or abortion in pregnant ladies. Hemolytic anemia, I will talk about how Lawson will produce pallor and yellowish discoloration and gene toxicity when it is taking oral. But this is proven in mice, and lastly is lymphoma, but we don't know the percentage yet. Dr. the late Frank Oski, the famous pediatric hematologist, he was, I think, in Kuwait or in Bahrain in 1990, and he have seen henna in the market. Then he said, I am sure that in this region of the world which has G6PD deficiency, this product might cause a problem. And he was right. He took samples to the state, and they discovered the mechanism of Lawson. You know that G6PD is very important in stabilizing the cell membrane and generating ATP and ADPH. Lawson, what will happen? This is the normal pathway that you need to reduce NADP to NADPH. This one, Lawson, it will be incorporated with the G6PD phosphate, and it prevents NADP from being reduced. So there is no production of GSH, then the erythrocyte membrane will be vulnerable for hemolysis, and this is what happened, hemolytic anemia and G6PD deficiency with henna. This is why henna is being, red henna is being contraindicated in G6PD deficient patients. And before that, there was a lot or several case reports, hemolysis after henna. You can see here, there are 9 reports that I have seen before the discovery of that Lawson causing this problem. Black henna is a combination of red henna and paraphenyl adenine. And this substance is mainly known to make henna from red, change it to black color, and to make it more more life. So it is discovered in the 19th century, and sometimes even it can cause permanent hair dye or chemical hair dye. So it is an alanine derivative and turn black due to the oxidation in air after mixing it with either henna, or it is being prepared alone with water, and it is sometimes being contaminated with heavy metal. What is the adverse event here? It is very allergic. You can see severe dermatitis and sometimes scarring can be because of the contact, chemosis, lacrimation, blindness reported, oral ingestion. It will cause obstruction of respiratory tract, and 7 gram to 10 grams is the lethal dose for ingestion. And the other side of red henna, like G6PD deficiency, hemolysis is being there. I think then another thing with the black henna, it can cause acute renal injury because of this material being ingested, or it went to the blood. So
Dr. Munir, Dr. Munir, please, you exceeded your time. Please summarize.
This is my last. Then
Okay,
it can
thanks.
cause
Thank you.
hemolysis because of the red cell-like HUS. This is what will happen. In summary, Lawson and the derivatives of Lawsonia, they are promising potentials for treating several diseases, including hematological, antifungal, antiviral, and antiparasitic. These agents need to be more investigated and to be involved in clinical trials as phase 2. Some of them, they finished phase 1, but need to be pushed into phase 2. Physicians should be, again, as healthcare workers, to know about G6B deficiency and the relation between it and henna, because it is very common in our community. And thank you very much, Doctor. Any questions?
Thank you so much, Dr. Munir, for this excellent presentation. It's very, very interesting topic and interesting usage in the future. Now, there's one question for you. Any transdermal benefit from using henna for any of its compound? Yani already
most
you
of
answered
these
this.
most of these things they have used henna as extract topically, and even for Lawson they said red henna is Lawsonia, but the active component, the main one for sickle cell and anti-tumor activity, anti-inflammatory, is the Lawson. So the Lawson being used topically, and now they are trying to make it oral. So many of these effects, it is topical. Mainly, it is in the lab. It is proven in laboratory and at animal level, which is the first step. No use for use
It will be in the
in
future,
human, except
future
on
usage.
diffuse ulcers and bear as topical.
Okay, thank you so much, Dr. Munir. We move to the next.
Thank you.
Thank you. We move to the next speaker. Our next speaker is Dr. Amira Rali, consultant hematopathologist, Salmania Medical Complex, Bahrain, senior lecturer, Arabian Gulf University. With over 20 years of expertise, Dr. Radi is a leader in hematopathology and transfusion medicine, holding fellowship from King Saud University and the Royal College of Pathologists of Australia. She combines clinical service with academic mentorship and has previously led the Bahrain Association of Pathologists. Please, Dr. Amira.
Assalamu alaikum.
Wa alaikum assalam.
I hope I'm sharing the my screen. Is it clear?
Yes.
Okay. So first of all, salam alaikum, or good afternoon to the audience. And I would like to extend my thanks to Dr. Najat and her organizing committee for this invitation. So my talk today will be concentrating on the recognizing the Schwann-Diamond syndrome in children. And through my lecture, we will go through the understanding of the genetics and the pathophysiology of the SDS, recognizing the hematological and systemic manifestation, and reviewing the diagnostic approach and the differential diagnosis, and tackling a little on the current management and prognosis. So first of all, Schwann-Diamond syndrome is a rare inherited bone marrow failure syndrome, and it is characterized by exocrine pancreatic insufficiency, bone marrow dysfunction, and skeletal abnormality, with increased risk of myelodysplastic syndrome and acute myeloid leukemia transformation. The epidemiology of this disease, it is a rare autosomal recessive disorder in most of the cases. However, there are some reported autosomal dominant, which is related to de novo mutations. The incidence of this disease is 1 in 75,000 to 100,000 live birth, and it's most commonly caused by mutation in the SPDS gene, and it usually presents in infancy and in early childhood. So talking about the genetic and the pathophysiology of the disease, the commonest mutation, which is the SPDS gene mutation, which is found in 90% of the cases in chromosome 7, and this will affect the ribosome biogenesis. Other SDS-like disease, which are involving other gene mutations, protein mutation, which are the EFL1, which is the elongated factor like GTPase, the DNA heat shock protein family, member C21, and lastly is the signal recognition particle 54. And these three genes are also involved in the protein synthesis and affecting the ribosome biosynthesis. The commonest presentation, that hematological presentation, are the neutropenia, and these patients also will have impaired hematopoiesis and cellular, leading to cellular stress also. Multi-system are involved due to the defect also of the cell proliferation. So in the next slide, as we know that protein synthesis will depend on the ribosomal biosynthesis and the ribosomal translation of messenger RNA into the polypeptide that are processed to the protein synthesis. So the ribosomal biosynthesis began with the import of this protein from the nucleus through the to the cytoplasm. And the relation of this protein in the assembly of the unit 60S and the 40S to produce the 80S protein unit for starting the translation to the protein production. So the DNA C21 will bind to the what we call the pre-60S, and it involved in the early nuclear ribosomal RNA biosynthesis and the maturation of the pre-60S to the mature type, which is the 60S ribosomal subunit. Then we have the SPD with the combination of EFL1, which interact together to release the ELF6 that facilitate the assembly of the mature ATS ribosome. And the last, but not what is known now, which is the SRP complex, and this complex, from its name, it consists of 6 proteins that are arranged in a long non-coding 7-SL messenger RNA. This helps the route for the polypeptide to go to the Golgi apparatus for further modification and shipping to the specific subcellular component. So it is a bit a little complicated, but I hope this slide have illustrate the role of the different proteins. Then on my next slide now, now we have an impaired ribosome assembly, which is the main effect, where there is also loss of the SPDS expression. And this in part will lead to a different effect, like the alteration of the certain cytokines and dysregulation of the F-actin polymerization, and this will lead to impaired neutrophils and monocyte chemotaxis, leading to reduced migration and chemotaxis, and this make the patient more prone to bacterial infection and actually recurrent bacterial infection. Also, this will lead to increased fast signaling pathway. That will lead to increased apoptosis of the hematopoietic progenitors, and also reduce the CD34 progenitor stem cells, and arrest of the myeloid progenitor differentiation to the stage of neutrophils, and this will add on the presence of neutrophilia. On the other hand, there will be also impair of DNA repair mechanism. There will be leading to also bone marrow impairment, delay, and ossification. There will be increase in P53 signaling pathway, and this will lead to different changes that we see in the pathogenesis and the pathology of the disease, where there will be increase of fat infiltration in the parenchymal of the pancreas, atrophy of the pancreatic acinar cells, so there will no longer be having the exocrine enzyme release, and they will give a high risk of MDS and AML transformation. So the triad of the Schwammen-Diamond syndrome, these patients will present with hematological abnormality like neutropenia, pancytopenia, bone marrow failure, and increased risk of malignancy. Also, the exocrine pancreatic insufficiency, where there will be a malabsorption, a fatty stool, abdominal distension, and failure to thrive because of the nutritional malabsorption. Skeletal changes that is seen with the syndrome is the metaphyseal chondrodysplasia, short stature, scoliosis, and dental abnormality. So the common presentation that is seen with these patients, they come with a recurrent infection, failure to thrive, chronic diarrhea or steatorrhea, anemia, thrombocytopenia, skeletal deformity, transient hepatitis, skin rash, eczema, and development delay in some children. What are the findings that we see as the hematological findings. In the bone marrow, you'll see hypocellularity, myeloid maturation arrest. So there is no more development into the mature neutrophils. Also from the myeloid dysplasia, changes in myeloid, erythroid, and the megakaryocyte. And variable cytopenia, so they may present with isolated neutropenia or bicytopenia or pancytopenia, and they have the risk of progression to MDS and AML that's been presented in the bone marrow findings. So what is the differential diagnosis of these? It's the bone marrow failure inherited syndrome. We have the Fanconi anemia, the diamond Blackfan anemia, severe congenital neutropenia, the Kosman, Pearson syndrome, and cystic fibrosis, which we'll go through this slide discussing the common overlapping features and the distinguishing criteria. So the first is the cystic fibrosis, where these patients will have in common with the CDS, they will have malabsorption, steatorrhea, and failure to thrive. The distinguishing criteria is the lung disease, the elevated sweat chloride, and there will not be, in these cases, no bone marrow failure. The pathognomonic طبعا genetic findings is the CFTR gene positive. The Pearson syndrome, the patient will have exocrine pancreatic dysfunction, they will have pancytopenia, but the distinguishing will be the mitochondrial DNA deletion, lactic acidosis, and the pancreatic fibrosis that's seen in these patients, with the hematological changes seen in the bone marrow, where they will have vacuolated erythroid precursor and ring sideroblasts in the marrow stained by the iron stain. Fanconi anemia is another bone marrow failure, which the patient may present short stature, cytopenia. However, they will have the physical malformation with the radical ray, thumb defect, and skin pigmentation. And it is diagnosed by the chromosomal breakage on the exposure to mitomycin C or diepoxybutane. Diamond Blackfan anemia, they will have macrocytic anemia, which can presented with the patient with SDS, and they will have physical anomalies. However, the distinguishing criteria in bone marrow is that they will have a pure red cell aplasia without a neutropenia, and there is or pancreatic dysfunction. And they will have the elevated erythrocyte adenosine deaminase with the RBS RPL gene mutation. Dyskeratosis congenita also have overlapping with the SDS, with the bone marrow failure and the cytopenia, but the distinguishing will be the mucocutaneous triad that is seen, which is the nail dystrophy, oral leukoplakia, skin hyperpigmentation, and the presence of tetra or TERIC mutation in the molecular diagnosis. The last one, we have the Kosman, which is the severe congenital neutropenia. And this patient, we will have profound neutropenia, recurrent severe infection as in SDS. However, there will be isolated hematological lineage defect, and they will not have the pancreatic or skeletal involvement, plus that they will have the abnormality in ELANE or HAX1 genes mutation. So when we want to diagnose SDS, we have to look into different parameters. The first parameter, we have the diagnostic hematological changes, where the patient will have a neutropenia less than 1.5 diagnosed twice within 3 months, cytopenia confirmed twice within 3 months, or additional study where we will have persistent elevation of hemoglobin F at least twice within 3 months, or persistent erythrocyte macrocytosis within 3 months, which is not associated with hemolysis or nutritional deficiency. And in looking to the bone marrow, there is dysplastic changes, there is increased fat deposition, and the number of the myelokaryocyte are vary with delayed neutrophil maturation. The exocrine pancreatic insufficiency is also one of the important to recognize, to diagnose the SDS, where there is decrease in pancreatic enzyme according to the age, the fecal elastase reduced, the serum tryptosinogen, which is less than 6 microgram per liter, serum isoamylase, and serum lipase. There is additional study that we can also prove where there is 72-hour steatoria study. We have decreased level of at least 2 fat-soluble vitamins, the ADIC, and the presence of pancreatic lipomatosis confirmed by ultrasound, CT, and MRI. Additional, we have the bone tissue abnormality and the presence of a first degree family member diagnosed with SDS. Now, the gold standard confirmatory test is the genetic testing, which looking to the mutation in the SPDS gene, and which is seen in 90% of patients, in addition to mutation on chromosome 11, inversion of chromosome 9 pair, which is associated with this pathology. So what is the working diagnostic test? We will do the CBC with differential, bone marrow aspiration biopsy, pancreatic enzyme assessment, genetic testing for SPDS mutation, and skeletal imaging. Now, looking to the changes that we see in the bone marrow, we say you will see a hypocellular marrow, there is myeloid hypoplasia, dysplastic neutrophils, and variable erythrocyte and megakaryocyte abnormality. To start with, we will assess with the assessment of cellularity of the bone marrow, which is assessed by the ratio of the hematopoietic cells to the fat expressed as a percentage or a grade. So we will grade it as hyper, normal, or hyper, where we can see here in the graph the hypercellularity, where the cellular component is more than the white material rounding, which is the fat, and the normal cellular here, where is a balance between 40 to 80, and it depends on the age to evaluate. Now, the last, which give you a hypocellular, where you can see the adipose cells, which is the fat cells, is more than the cellular component, and this is what we are seeing in case of SDS. Also, we will see that there is a myeloid hypoplasia, mean that there is marked reduced level of the myeloid component, and you can see in the lower image the big cells, which are the megakaryocyte, and the dark red blue cells, which are the erythroid, and there is barely myeloid cells in the higher magnification with mature segmented neutrophils seen in that bone marrow aspirate. So to talk about the neutrophils and the dysplastic neutrophils, there is many pictures of dysplasia where we see the hypersegmentation, the hypolobated and not lobated neutrophils, the pseudo-Pilger-Hewitt, which is the D marked here, and the hypogranulation neutrophils. So all these are images of a dysplastic neutrophils that we see in the bone marrow. So how we manage these cases? Now, it is a multidisciplinary management that include pancreatic enzyme replacement, nutritional support for any nutrient deficiency, infection prophylaxis, GCFs for severe neutropenia, and the hematopoietic stem cell transplantation in selected cases. The complication that these patients will go through is they will have recurrent severe infection, and they will have bone marrow failure. They transform to myelodysplastic or acute myeloid leukemia in 10 to 30% of cases, endocrine and skeletal complication, and the improved with survival will be related to early recognition and supportive care. I reached to the last slide with the key takeaways, home messages. STS is a rare but important inherited bone marrow failure syndrome that we have to have an early recognition to improve the outcomes, and bone marrow finding may provide a critical diagnostic clue for the diagnosis, and genetic confirmation is very essential in confirming the disease, and long-term multidisciplinary follow-up is required to alleviate the complication and to early detection of dysplasia and transformation of acute leukemia. With this slide, I will end my presentation, and I'm happy to answer any question. Thank you.
Thank you so much, Dr. Amira, for the excellent presentation. And as we don't have questions for you, we will move to the next speaker. So the next speaker is Dr. Zainab Tourani. She is currently completing. Dr. Zainab Tourani is currently completing a prestigious fellowship in hematopathology at Yale University, a graduate of Royal College of Surgeons, RCSI Medical University of Bahrain. She completed her residency in anatomical pathology at Salmania Medical Complex and achieved board certification through Arab Board. Recognized for her academic contribution, Dr. Tourani has served as a clinical pathology tutor at RCSI Bahrain and has authored numerous peer-reviewed publications. Please, Dr. Zainab.
Hello, everyone. Thank you so much, first of all, to Dr. Najat for giving me this opportunity and to the organizing committee. Okay, without any further ado, so my lecture is about beyond Langerhans cell histiocytosis, pediatric histiocytosis. I do not have, okay, perfect. So then we have the learning objectives. I'm going to be going through the WHO 5th edition classification, and then I will be talking about the various differential diagnoses and a few algorithms that I've created, and a little bit about molecular and targeted therapy. So starting with the historical evolution of the WHO classification. So this classification, histiocytic neoplasm, it represents a heterogeneous class of diseases with varied clinical and prognosis, including the Langerhans cell histiocytosis, Erdheim-Chester disease, Rosé-Dorfman disease, and juvenile xanthogranuloma and histiocytic sarcoma, and the indeterminate ones. The classification of histiocytic neoplasms, it has evolved over time, and there are many different advancements in our understanding and of these disorders. So back in 1987, this was basically classified primarily into the Langerhans, non-Langerhans, and malignant histiocytosis. However, this classification faced a lot of challenges as emerging deep sequencing diagnostic methods have revealed shared molecular features. You're going to come and see further what I mean by this is that these neoplasms, like for example, in LCH and Erdheim-Chester disease, you're going to see a lot of shared molecular features. In response to these insights, the Histocyte Society, they revised this classification in 2016, and then there was a new framework that was incorporated, and it actually kept in consideration of clinical, radiographic, histological, phenotypic, and molecular features, and it basically divided this disease into 5 main groups, which is the Langerhans-related histiocytosis, cutaneous and mucocutaneous histiocytosis, malignant histiocytosis, Rosay-Dorfman disease, and HLH and macrophage activation syndrome. Then there was further refinement that was done, which is in the WHO classification 5th edition in 2022, and it places the dendritic cells and histiocytic neoplasms after myeloid neoplasms, and it recognizes their origin from common myeloid progenitors, and we'll look at table 1 soon. So this classification, it basically organizes these neoplasms into 3 main groups. We have the plasmacytoid dendritic cell neoplasm, Langerhans cell and other dendritic cell neoplasm, and histiocytic neoplasm. So the first group, it includes mature forms associated with myeloid neoplasm and blastic variants. The Langerhans, the second group, it involves the Langerhans cell histiocytosis, the sarcomas, and other dendritic cell neoplasms include the indeterminate ones and interdigitated cell tumors. And the last group, it encompasses a different spectrum of disorders, including the juvenile xanthogranuloma, ECD, RDD, the ALK-positive histiocytosis, which is a new emerging pediatric entity, and histiocytic sarcoma, each with distinct clinical implications. So this is the table 1 that I was talking about. And basically what I'll be, sorry for the text, it's quite small, but I'll be focusing on this aspect because these are our main differential diagnoses that we'll be focusing on. Okay, so I wanted to play with AI a bit. So I fed it a few information and it made this very beautiful summary of all those entities. So we have the LCH group. So basically, so we are going, our lecture is about beyond Langerhans cell histiocytosis. In a Langerhans cell or a Langerhans cell, you're going to see those cells that are atypical histiocytes with reniform nuclei, and they are classically positive for CD1A and S100. And on electron microscopy, for those who are entering into the board exams, they like to ask that you would see Burbank granules. And then we're going to speak about the rest. So why does this topic matter? Because it is rare, but it is diagnostically very challenging because many of them, they go through the same pathway. We're going to come to that. And we need to do important morphological and immunophenotypic distinctions so that we come up with the proper diagnosis. And the molecular classification has evolved very much over time, and that is important for the therapeutic implications. So let's get into the real stuff. So starting with a juvenile xanthogranuloma, it is a benign cutaneous dendritic cell related histiocytocytic proliferation, and there will be alterations in the MAP, ALK, BRAF, and the NTRK1, and usually they present with these nodules, and it happens in very young children between the ages of 6 to 9 months, usually less than 3 years old, and you're going to have those nodules being red to brown plaques or nodules. It can be up to 1 centimeter, it can be larger. And what is also to keep in mind that is important is that there can be a spontaneous involution that can occur over time. Some of the associations, this is also a board exam style question, is that the juvenile xanthogranuloma is related to NF1 and JMML, which is a juvenile myelomonocytic leukemia. And it will be of a higher prevalence in those patients, especially that also have NF1. The incidence is rare, it has a male predominance, and the prognosis is excellent, and it can, most lesions can regress or stabilize over time, rare deaths occurs from this. The developmental anomaly, we will have so it depends on which kind of mutation it is affecting. So we have the anti-RK1 expression. It is reported in solitary lesions. And then we have the MAP pathway if it is affected, or the ALK. And each one has its own kind of set of how extensively it will affect the system. So as we touched upon it a little bit, histologically, you're going to see this nodular mass that is poorly demarcated. And we are going to see these polygonal to spindle-shaped cells with indistinct cytoplasmic border. And we will have these, the cytoplasm will have this eosinophilic, amphiphilic cytoplasm. You will have this foamy histiocytes. And a key thing to look at is the two-tone giant cells. Mitosis is quite rare. You can see some inflammatory cells in between. So this is just a summary of what we would be looking for in a juvenile xanthogranuloma. It is the most common pediatric non-LCH histiocytosis. Typically, it's a cutaneous lesion in infancy. You would see those characteristic two-tone giant cells. We're going to look at pictures on this. And you will have positivity in the CD68, 163 positive, which are the histocystic markers, and factor 13A. And CD1A and Langerhans will be negative. These are the immunohistochemistry markers for Langerhans cell histiocytosis, and it's important to do them to distinguish it from a Langerhans cell histiocytosis. Electron microscopy is not very much done, but when you do it, you're not going to see Berber granule. As we mentioned earlier, we would see that in a Langerhans cell histiocytosis. So on grossly or clinically, we're going to see this nodule that has a slight erythematous border, is a bit raised, and it has this yellowish center in appearance. And under the microscopy, we are going to see these cells. So these cells are the two-tone giant cells. So these are basically histiocytes that are very much rich in lipid, and they kind of like coalesce, or they fuse together, and then they form this two-tone giant cell. So the characteristic feature of a two-tone giant cell, so you can see this nucleus that is forming like a rim in the border, like a wreath kind of appearance. So this is it, and you have an eosinophilic center. And this is also a characteristic thing, is that around it we are going to see this whitish area that is like how lipid rich it is. Okay, and so we're going to see these. Do you see this ballooned up kind of cells with very much pale cytoplasm and sort of vacuolated? These are the histiocytes that we would be seeing also in it. And here, this is just a pic to demonstrate that there can be inflammatory cells in between. So you see the red ones that has like very much granules, those are eosinophils. So another picture just showing you this black arrow, very tiny, but there are spindle cells in between, which are fibroblasts. And then we have these, again, the ballooned up, the puffed up ones with the very pale cytoplasm. These are histiocytes. And the white ones, extremely tiny. These are like the lymphocytes, basically. So these are the different, so we have this one, this is the CD163, I believe, that is positive, CD68 is positive, and the Ki67, so it's not very mitotically active, it's going to be low. So the main differential diagnosis that can be applied throughout the lecture. So we have xanthomas, which are, you can see foamy histiocytes, no two-tone giant cells that we just saw. There will be no background inflammation, and it is usually occurring, it is benign, usually occurring in adults, and they can clinically present with hyperlipidemia. Reticulohistiocytoma is a benign histiocytic proliferation, which typically occurs in adults. And basically, they form these nodules with two-toned histiocytes, and nuclear ATP is often present. And it will also be positive for CD68 and negative for the Langerhans cell markers. Langerhans cell histiocytosis, we just spoke about it a little bit. So, and something to keep in mind also in a Langerhans cell histiocytosis, which I didn't mention, is that you will have so much of eosinophil in the background. This is something also to keep in mind. It's not the only entity that has a lot of eosinophil in the background, but when you have it, you would be keeping that in your differential. Rosé-Dorfman disease, we're going to talk about later in a bit, actually. The dermatofibroma, it happens in adults. You have a typical collagen trapping, and there is mixed population of spindled and histiocytic cells. It has a very common story form pattern, and it is very much benign. Rare mets can happen. So Rosé-Dorfman disease, the synonym is a sinus histiocytosis. There can be massive lymphadenopathy related to it. And basically, you're going to see these large cells with abundant cytoplasm. And the characteristic feature about this is that you're going to have imperiopoiesis and S100 positivity. We're going to look at pictures on this. The incidence is rare. In the US is around 100 new cases of RDD per year, and prevalence is 1 in 200,000 persons. The age range is very large. It can be from really young to really old. And when it comes to the sex predilection, we have male more than female. I think like it's not showing the whole slide, but I believe there is no ethnicity that is like it really involves in it. I don't know if we can like zoom it out a little bit just to show the whole slide, because this is not the whole slide. Okay, so basically the sites that are involved, we can have involving the lymph nodes, and we also can have it extranodally involving, where it forms like a mass form kind of lesion. And basically it can happen virtually anywhere in the body. So traditionally it was kept in mind that lymph nodes are the most common site that is involved, and but in the recent Mayo Clinic study, it is the second most common site. So it mainly presents as it's like cutting off of a bit of points in the bottom. I don't know if the organizing committee can fix that. Anyways, so basically the presentation is that we will have these painless or painful subcutaneous mass, and lymphadenopathy is very much seen. And we can have the B symptoms is not very common to be seen here. There is no specific laboratory abnormality that you see. It's just some inflammatory markers can be increased, like CRP, ESR. And the plasma cells that are seen in Rosé-Dorfman disease, they're polyclonal. They are not monotypic. And 5 to 10% of the patients, they will have Langerhans cell histiocytosis related to it. Macroscopically speaking, these lymph nodes can be like enlarged. It can be very massive in size, and it can be mass forming. And we can have, if you remember a bit earlier, we spoke about imperiopoiesis. We can have some inflammatory cells in between, like the small lymphocytes, and plasma cells can be numerous. So we have these, so we said sinus histiocytosis. So we have dilated sinuses that are filled with these RDD histiocytes, and it is associated with these small lymphocytes and plasma cells, and there will be imperiopoiesis. Sclerosis happens in about 75% of the cases, and we have a very common reactive follicles all around. Mitosis is not very common to be seen. There are many etiologies related to it. The most common one is idiopathic, but infectious agents can be related to it. Genetics, if anyone who's going to enter into exams. So the rare familial forms like facial abode, histiocytosis, H syndrome, SLC2983. These are some genetic diseases related to it that has been reported in it. And neoplastic marker, we're going to hear MAP a lot throughout this lecture. So 1/3 of the cases, they carry mutation through that pathway. Autoimmune diseases related to it, we have rheumatoid arthritis, Sjogren's, SLE, all of that is related to it. And we have even, there are some relationship with the IgG4 related diseases. And as I mentioned earlier, that the plasma cells, they are polyclonal and not monotypic. So Obviously, we're not going to do all of these IHCs in a clinical setting or as a pathologist. So the main ones that we would be doing is the S100, which will be very much positive. We could do OCT2, which will also be positive. And we can do some histostic markers like CD68, CD163 is also going to be positive. And then it's important to rule out other things like Langerhans histiocytosis. So we are going to do a CD1A, Langren. The other name for Langren is CD207. And if you're suspecting other differential diagnoses, like let's say you're thinking about melanoma, you're going to do melanoma markers. If you're thinking about lymphoma, you're going to do some lymphoma markers just to rule it out. And then we come to so flow cytometry is not commonly done. ISH is not commonly done, but in genetic testing, we spoke about the gene mutation that is 1/3 of the cases seen is the MAP pathway. The KRAS and the MAP2K1 is the most common mutation. BRAF is not very much seen. BRAF is most commonly seen in Langerhans histiocytosis. And this is the gene that, or the also the genetic familial form that I was talking earlier that is related to Rosai-Dorfman disease. The treatment, so I think a clinician would be best at commenting on this, but basically the subset of the patients can be observed without therapy. Surgical excision can also be used as a modality, radiation and systemic therapy like corticosteroids. Something to keep in mind in general as pathologists is that when rituximab is used, it's important, that's why it's very important to have a clinical history, because let's say the patient was on rituximab and we did a CD20 and then we see a CD20 negative, is that it does not mean that the patient does not have like B cells. It just means that this particular treatment that was used is an anti-CD20. So you're going to have it negative under the microscope when you see it. So keep that in mind, because the rituximab is used in different, as treatment in different lymphomas, like follicular lymphoma, for example. Prognosis is quite excellent, and no effective therapy for these rare aggressive cases, and fatalities are not very common. So this is grossly how it looks like. I know a very like a boring gross image is that we are going to see this yellowish kind of center, and there are these dilated sinuses in between. When we come to see it under the microscope, these black arrows just shows you the reactive follicles that we would see in between, and then we have these lighter and darker areas. And when we focus on those lighter areas, we see these cells. So they are ballooned up, polygonal, abundant cytoplasm, pale to eosinophilic cytoplasm, amphiphilic, and then we see these big characteristic kind of cells. This is the imperiopoietic cells. Basically, they are they will have these other cells inside, so we can see lymphocytes, we could see plasma cells in the cytoplasm, and then it lights up beautifully with S100. So we can have this. Do you see it here? This is S100 being positive in multiple of them. Now, this is the new emerging entity, which is the ALK positive histiocytosis, a rare histocystic neoplasm. It is characterized by the ALK gene rearrangement. It predominantly involves in the infants, children, and young adults. So the characteristic feature here, finding, is that in the genetic pathway, you're going to see ALK positivity, and you are going to have ALK positivity even in by doing immunohistochemistry. And the morphologic finding is really, it really overlaps with the classic xanthogranuloma, and it will be very densely cellular when we look at it under the microscope. The most common gene fusion that is related to it, because it can have other fusion partners, but the most common is the KIF5B. ALK is the most common one. So we can have these other fusion partners, but it can have, and we can have also two-tone-like giant cells seen in it, and variable fibrosis inflammatory infiltrates can be seen. It will be very, very cellular. We can have epithelioid histiocytes infiltrated and abundant eosinophilic cytoplasm. It will be typically positive for CD68, 163, factor 13A, and ALK, which we mentioned earlier. And when you do a FISH and RNA sequencing, it will have an ALK rearrangement. So these are the differential diagnoses to keep in mind, which is quite commonly, I've repeated it along the lecture. And why the molecular rearrangement is important, because we can have then therapeutic implications related to it. And then this is how it looks like histologically. It's very cellular. And you can see, if you see some spindly cells in between, those are the fibroblasts. And then you have the ones that have like abundant cytoplasm. Those are our histiocytes. And then we do a CD163, which will be very nicely positive. And ALK, when we do, it will be very cytoplasmic positivity can be seen. Then Erdheim-Chester disease is a polyostotic sclerosing histiocytosis. So polyostotic, it means multiple bone, or it involves the long bone mainly. And sclerosing, you will see a lot of sclerosis, and you're going to see a lot of histiocytes. And the neoplasm that can involve many different organs, and it's composed of mature histiocytes. You have to keep in mind there's a neoplastic disease where it is associated mainly going through the the drill. It goes through the MAP cell signaling pathway. The BRAF is seen in around 50-60% of the cases. There are other MAP pathway genes involved related to it. The variant allele frequency, the VAF, is usually low, less than 5 to 10%. There are other mutations that can be seen in it, and it is thought that it arises from a myeloid progenitor cell or a macrophage. The incidence is quite rare, around 800 cases reported in literature. The age is around 5th to 6th decade, rare in children. Why are we discussing this? Again, because of how the biology is. I know that this is a children-based kind of conference, but it's important to keep in mind it does rarely occur in children. And it is biologically very much related to an LCH. So that's why I've kept this in the lecture. It has a more female predominance, and it affects mainly the long bones. It can infiltrate surrounding the kidney, which the radiologist would call it hairy kidney. And then it can also, if it surrounds the aorta, the sugar-coated aorta. So I've personally not seen them, but this is what I've read in the literature. And the presentation, they commonly present with fever, fatigue, bone pain, because it affects the long bones mainly. We have the exophthalmos, xanthelasma. The CNS can be involved, which is attributable to a tumor mass if it is seen presented as a mass. And 10 to 15% of these cases, they have other histiocytosis. This is also a commonly asked board exam style question, is that Erdheim-Chester disease in 5 to 10% of the cases can be seen in with CMML, which is chronic myelomonocytic leukemia. And the treatment, so you will be thinking about the pathway it goes through. Then you have a therapeutic implication related to that. The prognosis, it depends on the site and how extensive the disease is. And if it involves the CNS, it has a poor prognosis. So these are the radiological findings that I was mentioning earlier. And macroscopically, we are going to have these general feature, basically like biopsy specimens obtained from any part that it is involved. So you're going to take a sample from that, and we're going to see these histiocytes that are variable in number, very foamy, very lipid rich, and two-tone-like giant cells you're going to see. So when I speak about two-tone giant cell or two-tone-like means it's not very much well formed as in the juvenile xanthogranuloma that we spoke about earlier. And you can see some reactive small lymphocytes, plasma cells, neutrophils in between, and fibrosis is common. So the histocytic markers can be positive in it. So we have, for example, CD68, 163 will be positive. Factor 13A, it can be positive or negative. And the BRAF can be positive or negative. The Langerhans histiocytosis markers will be negative. And again, the plasma cells that are seen here are, again, polytypic. They are not monotypic. They are not clonal. The genetic testing is the MAP signaling pathway, and the VAP is not very high here as well. So this is what we are going to see, the spindle-like cells, which are these fibroblasts. And then we have these histiocytes, the more foamy ones with more abundant cytoplasm are those. And this is the two-tone-like giant cell. So if you compare it with the two-tone giant cell that we saw earlier, you can see that this does not have like a typical wreath kind of pattern that we would see like in the periphery, not very much of this lipid kind of pale cytoplasm around, or the eosinophilic center. And then CD68 will be positive, FASN can be positive in it. Then I know it's a benign conference, but this is an important differential that we have to keep in mind. You can't not. So we'll just quickly touch on it, is that histocystic sarcomas can be related, can be a differential, and basically they look very ugly. We have very polymorphic appearance. We have a lot of vesicular chromatin happening. We have a very polymorphic atypical histiocyte seen, and they can present as a solitary mass. It's very rare in children. Most commonly, it is seen in adults more than in children. The pathogenesis, I'm going to keep this for you to read at your own leisure, but basically there are two main theories related to it, which is the direct transdifferentiation and the two-step process lineage reprogramming. And it can also present as a de novo. The treatment, surgical excision, is curative if it is of a low stage, and chemotherapy can be used, and then depends on which signaling pathway it goes through. We can use different kind of inhibitors to target it, and prognosis favorable if the neoplasm it is completely excised. Otherwise, high stage lesions have a poor prognosis, and cases with BRAF is not associated with more aggressive disease. So generally, they come as a solitary mass. It can be very infiltrative. It can involve the soft tissue. And we are going to see these basically. We're going to come to pictures on the histological marker, how histologically it looks. So we have different molecular genetic mutations related to it.
Dr. Zainab, please, you have 2 more minutes only.
Sure.
Please summarize.
So we have the BRAF basically that is related to it. We're not going to touch on that. And then these are the immunohistochemistry markers, at least 2 of the following we will be doing. An important differential to keep in mind is a myeloid sarcoma, and these have a more blastic look. So when we go higher power on this lesion, we are going to see these very ugly cells that are polygonal, very atypical nuclei, pleomorphic, and vesicular chromatin. Mitosis is very much common, and there will be erythrophagocytosis seen here. And these are the positivity in CD68 and CD163. So HLH, I believe it was already covered earlier. So I'm not going to be touching on that. Just something that is important is that the diagnostic checklist is important, and hemophagocytosis is not, it's a clinical diagnosis, and we don't have to have hemophagocytosis. I just added something. So this is the diagnostic algorithm that I fed into AI, and it gave me this. Of course, there are gray zones to it, but it basically tells you how to come up with a diagnosis. And I've created these tables so that it will be, if you're not going to go through the text, you can go through these tables. It will be very helpful when it comes to looking at molecular morphology and how the immunohistochemistry marker being positive. And this is just the molecular landscape that is seen in each as a summary. This I've taken from a very nice paper that I've referenced below. I'll show it to you. And it also shows how much of these genes and how prevalent it is in each one of them. And the diagnostic pitfalls, I would like to just ask this as a quick quiz. not more than 30 seconds, Dr. Najat. So this was a case that we presented a few years ago. It was diagnosed with Dr. Zainab Harb and the radiologist with Dr. Rola Hussein. This is a gross image in a 15-year-old Bahraini female that presented with this solitary mass after a COVID-19 vaccine. And basically, so this is a quiz. Anyone who answers it rightly, if they're outside Bahrain, anytime they come to Bahrain, I'll be giving them a gift for this. So we have this nodular kind of pattern. And then when we go on higher power, we are going to see these cells that are very much ballooned up. These are histiocytes. I'm not going to say much if there are answers to it. So this is the next slide. There's a very characteristic cell here. If you can tell me what is the diagnosis. I don't know, and they are very much beautifully S100 positive. I don't know if anyone answered Dr. Najat on this case. What do you think this is? Yes, that is correct. Is a Rosay-Dorfman disease, and it happened. We presented it. We published it as a case report. It's very, very rare. Post-COVID-19 vaccine, mass-forming region, Rosay-Dorfman disease. So CD68 was also positive. And these are my landmark references, and these are my suggestive reading. This was the paper that I was talking about. Very nice. It explains about the basics and everything. So it's okay.
So thank you so much, Dr. Zainab, for the excellent presentation. We move now to the, I'm sorry, because we have still one more presentation. Thank you so much, Dr. Zainab. Very interesting and excellent presentation. So now we move to the next speaker. Next speaker is Professor Mohammed Habbal, consultant, physician, and nephrologist. Professor Al-Habbal is an eminent consultant, physician, and nephrologist with distinguished career spanning clinical practice and medical education across the Middle East. He has been instrumental in teaching undergraduates and postgraduate medical students at leading institutions in Iraq, Yemen, United Arab Emirates, and Kingdom of Saudi Arabia. A prolific scholar, Professor Al-Habbal has published extensively in fields of internal medicine, nephrology, and human lactation, establishing himself as a respected authority and contributor to the advancement of medical knowledge in these disciplines. Please, Professor.
Mrs. Chairman, dear colleagues, Assalamu alaikum wa rahmatullahi wa barakatuh. Can I share my presentation?
Yes, please share your presentation.
My topic is about a novel breast milk stem cells for treatment of thalassemia infant as a controlled pilot study. This study was conducted in Thalassemia Center of Mosul, Nineveh Governorate, started on 2022. And this is the picture of the team of our treatment project. We are 4 authors, led by me, and as you know, thalassemia is a major and severe. Thalassemia major is a severe disease that can be fatal if untreated or improperly treated. There are 4 main therapy options, including blood transfusion, iron chelating therapy, and recently gene therapy, and bone marrow transplantation. The last 2 are costly and need highly specialized centers with many side effects as immune response, which might lead to many side effects and spread inflammation. Recently, it has been reported that breast milk is a novel source of stem cells with multi-need differentiation potential, and microRNA for gene expression regulation. These components can survive the infant gastric juice, absorb, migrate, and integrated into different organs, including the bone marrow, where may provide developmental benefit to the diseased infant. There is an alternative treatment hypothesis actually done by me that human milk from a healthy, non-related lactating mother, wet nurse, may replace of these invasive therapies. As well, this can be depends on the advantage of the genetic materials present in the breast milk of the wet nurse to be passed and integrated in the different organs of the affected infant. This hypothesis was put by me, originated from Islamic teaching called brotherhood in lactation, milk kinship, الرضاعة الأخوة من الرضاعة. This was published by me and my colleague, Dr. Wamid Al-Umari, in our book published in 1995. Please, since this 1995, we put this hypothesis that possibility of the genetic materials transferred through the breastfeeding from a healthy unrelated nursing mother to an infant, which may be a beneficial effect by repairing or modulating of the abnormal gene affected. And this is my book, which was published in 1995. And that there is a chapter of this hypothesis, which I said, نظرية للتحقيق والتطبيق. This was actually derived from قوله تعالى بسم الله الرحمن الرحيم وإن تعاشرتم فسترضع له أخرى. كما تعلمون, the Islamic teaching suggests breastfeeding as from mother or from non-mother. في قوله تعالى بسم الله الرحمن الرحيم في الآية 233 من سورة البقرة والوالدات يرضعن أولادهن حولين كاملين, which was documented by WHO recommendation that breastfeeding from mother to continue up to 2 years. And also this ayah ولا جناح عليكم أن تسترضعوا أن ترضعوا ولا جناح عليكم أن تسترضعوا أولادكم إذا سلمتم ما أخذتم بالمعروف. ففي نفس الوقت يشجع على الرضاعة الأمومية وعلى الرضاعة البشرية. But about this unique ayah, which we derived it from our research hypothesis and application, that if a family, they have one child or more with sickle cell disease or thalassemia, and the mother is pregnant, they will be in a dilemma and difficult situation whether this embryo is affected or not. In Western countries, they will do antenatal diagnosis, and if the fetus is affected, they will induce abortion, which has many side effects. But in our Islamic teaching, this abortion is prohibited because it is the killing of a soul. So Bari Azza said, if you have a difficult situation about this child, infant, whether affected or not, فهيئوا له مرضعة. Prepare another healthy nurse to feed him. This may her breastfeeding may help him to reduce this disease. So this hypothesis, which was put by me and published in books and many meetings before the discovery of stem cells, which was discovered by Professor Mark Gregan from Western Australian University in 2007. So also, as you know, amniotic fluid contains these stem cells, And there is now to do amniocentesis and separation of these stem cells for treatment of sick children for many diseases. And breastfeeding is actually is a continuation of this scenario that may replace separation and treatment, which is a natural way. So as far that amniotic fluid and breast milk stem cells are available them for the treatment of familial hereditary diseases, especially breastfeeding, which is a natural and oral method. Previously, in 2020, when I was in Andaman King Fahd Surgery Hospital, I diagnosed a patient with sickle cell anemia. I encouraged her, of course, to take that breast milk feeding from another healthy wet nurse beside her current treatment. And I followed her for several months, comparing her condition with other siblings. She had two brothers, one 2 years and one 4 years. As you can see from this slide, she was healthy looking in comparison with her sibling, less crisis and no hospitalization, while her siblings, they have frequent crisis and hospitalization. Hemoglobin was almost within normal values in comparison with her siblings, and she had no bone necrosis, aseptic necrosis, which is a common complication of sickle cell disease, as you know. And there is no history of a blood transfusion, as far as she was suckled by a wet nurse, a healthy wet nurse. So this case report, which was published in the article in 2022, encouraged me when I returned back from Saudi Arabia Kingdom to Mosul to conduct a large clinical study in our thalassemia center to do research with my colleagues, which I saw their name and picture. And we collected 8 patients, 5 males and 3 females, diagnosed having thalassemia major, fed by non-mother breastfeeding from 3 to 6 months. For about 6 who were fed by their biological mother. So we have 2 groups. The group A, they were fed by healthy non-related mother. Group B by their biological mother for the same period. And of course, we took the consent of the family, the parents, and the donors, which as we check the donors to be not related, because if they are related, they may have the same genetic material. And actually, in this situation, I remember saying of أمير المؤمنين علي بن أبي طالب رضي الله عنه كرمه وجهه يقول: تخيروا للرضاع كما تخيروا للنكاح فإن الرضاعة يغلب الطباع. For the diagnosis of our patient depends on clinical assessment plus general condition and blood examination, CBC, which showed blood film hypochromic microcytic anemia, target cells, etc., chromatography, and also we did genetic study. To clarify with the type of the thalassemia and for hepatosplenomegaly by doing ultrasound in the beginning and after 6 months. The findings indicate that after 6 months of non-mother breastfeeding, there were significant improvement in both hematological and clinical outcomes, including reduced splenomegaly and decreased frequency of blood transfusion compared to the control group. Genetic study as showed beta thalassemia major for all of them. In conclusion, non-mother breastfeeding could be a safe, effective, non-invasive oral therapy and cost-effective option for managing beta thalassemia major infants. And this table summarized our result, including that hemoglobin was significantly increased, while in the control group there was no improvement. They were taking blood transfusions every three weeks. Hemoglobin A significantly increased, while in the control unchanged. Hemoglobin F significantly decreased, while in the control remained almost the same. And interest point, there was a reduced frequency of blood transfusion. In the treated group, they usually blood transfusion every 5 to 7 weeks, while the control group, they usually receiving blood transfusion every 3 weeks. Also, the spleen, there was a decrease in splenomegaly. General condition was normal in the treated group, or retarded in the other group. And the result of the parameters in all our patients, including hemoglobin, HPLC, also splenomegaly, frequency of blood transfusion, general condition in details. And this is a sample of the genetic study done in our specialized lab, which showed homozygous thalassemia major, the brand from China, from India and Middle East analysis. The term is from Middle East type of thalassemia, as you can see in this genetic study. So the advantage of human lactation therapy, breastfeeding therapy, compared with genetic or bone marrow transplant therapy, our natural method of treatment, it is a healthy lactating from healthy donor compared with highly specialized donor for bone marrow transplant. In our method, it is safe, simple, no dying risk, while the other methods are complex procedures, as you know, with many side effects, which is also risky and costly, while in our method, it is natural, cost-effective, and economic, and it is non-invasive oral, while the others are invasive. In our cases, it is natural and nutritional, while the other methods non-natural and non-nutritional. Breastfeeding are available, while the other methods only in a few high specialized centers, and no need for hospitalization, while the other need long hospitalization with 85% successful and 5% dying possibility. While in our method, it is safe and effective. Actually, we can conclude that human lactation, breastfeeding from a healthy, non-related mother may replace the need of the following. This human milk stem cells, they will form a new line of healthy cells through what is called chimerism, which may replace the bone marrow transplant, because the healthy stem cells from the natural non-mother breast milk contain stem cells which integrate in the bone marrow and may induce and form a new line of healthy RBC, and that's why it's called chimerism. Instead of a previous population of RBC, there will be a new line of RBC which may replace the disease load or at least suppress it. Also, the microRNAs, there are more than 1,400 of microRNA in the breast milk, human breast milk, which are responsible for gene regulator called gene regulator, which may replace gene therapy. Because this microRNA, through methylation and acetylation, may suppress the abnormal gene and stimulate the normal gene. It works as on or off, turn off or turn in. There will be no change in the genome. The genome is the same, but there will change and modulation in the type of the gene. The disease gene can be suppressed by this healthy microRNA, and the healthy gene can be stimulated and encouraged. So there will be improvement through these two underlying mechanisms. In conclusion, we are reporting for the first time the treatment of infants suffering from thalassemia major by a healthy non-related mother milk for about 6 months in comparison with a control group fed by their biological mother. Our recommendation, because our study is still in its beginning for the last 4 years, so the early diagnosis, prenatal diagnosis, if we diagnose as early as possible through family history or through antenatal diagnosis, and breastfeed the affected thalassemic infant from a healthy, non-related wet nurse, to start breastfeeding as early as possible for a sufficient period. Because as far as introduce this mode of treatment early as possible, because it can penetrate easily and pass through intestinal blood barrier, because the filtration and GIT is not mature, and the immune system also is not mature of infant. So there will be marked and better advantage and the result if we treat them as early as possible with a good and sufficient days, at least for 2 to 3 months. Of course, our study is a preliminary one. We are still collecting more cases, and further studies are needed, might be multi-center studies. Also, we are doing long-term follow-up to know the sustained benefit and improvement for this treated infant, whether this infant developmental and hematological is sustained and for how long, and we may present that in a next meeting. Thank you for listening. Wassalamu alaikum wa rahmatullahi wa barakatuh.
Thank you so much, Professor Al-Habbal, for this excellent presentation. Very interesting, and I think it's promising as well. I mean, there is 2 questions for you. One, I suppose you already answered them. Have you done any follow-up study as how long breastfeeding will be continued?
Yes, we are doing phase 2 now, following those infants who are now 3 or 4 years old, to see the sustained improvement, and doing also serum ferritin as another marker because to know whether they need less chelating agent in comparison with the control. Thank you for this intelligent question.
Another question: for how long child with beta thalassemia major will have less severe after stopping breastfeeding milk? And the question: what was the pathophysiology of breastfeeding milk to cure or improve the thalassemia?
Through these stem cells, the active stem cells present in the human milk, this is passed and integrated in the different tissue. This was conferred by Fontani Kokalis, also from Western University of Australia. She confirmed that this is passing and integrated in different organs, including the thymus, the liver, the brain, the bone marrow. So they are generating a new healthy cells. As you know, stem cells, what is that? It is a revolution in the medicine now, stem cells, which can form a healthy new cells for the affected infant. So there will be a line of healthy RBC, which may suppress the disease one. And also the second mechanism, through epigenetic effect of the microRNA, which can suppress the abnormal gene, as if we are replacing gene therapy through this microRNA, which are very abundant in the human milk.
Thank you so much, Professor Habal, for this very interesting presentation. And we would love to invite you in the future in our next conference to see the follow-up on your patients or cohort patients, to see to follow the results or the outcome of this very interesting treatment.
Inshallah. So I promise you, maybe next year we will have a data for a follow-up. Inshallah.
Inshallah. Thank you so much. Now we come to the end of our conference. As we, distinguished faculty, esteemed colleagues, and dear friends, as we bring the 7th International Pediatric Hematology Conference to a close, I would like to take a moment to reflect on the remarkable journey we have shared over these past 3 days. This conference has been a true celebration of excellence in pediatric hematology. From the very first session to this concluding moment, we have witnessed outstanding scientific presentations, engaged in thoughtful and inspiring discussions, and built meaningful connections that transcend borders and disciplines. We have explored the frontiers of gene therapy, transfusion medicine, hemoglobinopathies, coagulation disorders, iron metabolism, and transformative role of innovation and artificial intelligence in medicine. More importantly, we have been reminded that behind every scientific advance and every clinical insight lies a shared purpose to improve the lives of children and families who depend on our expertise and dedication. To our distinguished international faculty, thank you for your generosity in sharing your knowledge, experience, and vision. Your contribution have elevated this conference and inspired all of us in attendance. To our delegates, your active engagement, thoughtful questions, and enthusiasm have been the heart of this meeting. You have made these days both productive and truly memorable. As we return to our respective institutions, let us carry with us the knowledge gained, the collaboration formed, and the renewed commitment to excellence in our practice. May the spirit of this conference continue to inspire our work and strengthen our shared mission in the months and years to come. On behalf of the organizing committee, thank you once again for your presence, your passion, and your unwavering commitment to advancing pediatric hematology. We look forward to welcoming you again at the next edition of the IPHC. Thank you and goodbye, and see you next year, inshallah.